Doctor, we are live now.
Thank you. Good morning to all. On behalf of myself and Tamil Nadu Ophthalmic Association, we extend a warm welcome to all the judges, panelists, and speakers of the today webinar on controversies in glaucoma management. All of you know very well that World Glaucoma Week is observed or celebrated all over the world from March 12th to 18th. It was over yesterday, but we are having this webinar today. This main purpose of this World Glaucoma Week is just to make create an awareness among the all sectors of people, whether it's a common public person and the health personnel and glaucoma patients and even ophthalmologists, how to diagnose glaucoma early and overall the risk of developing glaucoma. Well, all these things matter because there is nothing wrong, no point in diagnosing glaucoma in its advanced stages, and we say we cannot do anything. But main key is the early diagnosis and going them for preventing going them for blindness. That's the main aim of this World Glaucoma Week. Of course, all of you are aware of the theme of this year. The world is bright and save our sight. So in that way, we have done so much of awareness activities for the last 1 week, spread over all over India and all over the globe, in the form of awareness talk and exhibitions, awareness various TV shows and on the radio, so many activities. So that way, we thought we can have a webinar on glaucoma. And of course, we couldn't conduct during that week. So we thought Sunday would be the better option so that many people can attend. So in that way, Dr. I have asked Murali and Krishna to formulate a webinar. So they have given a wonderful program today that very commonly just raise doubt in everyday day-to-day practice. They selected 6 important topics with good speakers. And also, you have to thank all our judges, Krishna and Vijaya, and panel eminent glaucoma persons, and also the speakers. And special thanks to Murali and of course Krishna. And I'm very happy this time that all the speakers, most of the speakers are very from younger generation. Very a good sign. So many glaucoma people are in the field, so that we can do much more better to our patients. So these few words I'm eagerly waiting to see the debate, and also we can learn all of it, because every day is a learning day. So it's a wonderful topic and wonderful speakers. I don't want to add in between. Before giving the mic to Dr. Murali, I thought our President-elect, Dr. Nirmal, will give a few words about the World Glaucoma Week. Murali, Nirmal.
Thank you, President. Thank you for organizing this wonderful webinar on debate and controversies. So this is one field where there is a lot of debates going on, right from the basics toward the advanced stages. I'm happy you have involved the senior most glaucoma specialist, and as you rightly said, covers the basics to the recent advances, the structures as well as the MIGS and the recent diode. All these concepts have been incorporated into the webinar. We are all looking forward to hear the debate and take the important points. I think we should also include certain social debates. Most of these health-related subjects are taken only by the medical professionals within our associations, and very difficult to take this to the general public and the policy initiatives and the lawmakers. I think we should explore and have debate along this subject also, to take the subject to the public as well as to the lawmakers, to ensure easy availability of drugs affordability of the drugs, as well as early detection and getting the treatment initiated at a much earlier. The common problem we face is we start the medication and somebody tells this is costly, or go for generics, or some other try the naturopathy or other set of medications. So most of the patients tend to have very poor compliance. I think we should also address this as part of policy initiatives from our association side. And thank you so much. I'm also eager to listen to the experts. Thank all the panelists, judges, and the moderators to be part of this initiative. I'm looking forward to hear from all of you. Thanks a lot.
Thank you, Dr. Nirmal. And Murali is.
Yeah, thank you very much, sir. And I think Dr. RK sir has to be congratulated for initiating wonderful topics and discussions and webinars in the TNOA since he has taken over. And each event and each webinar he has organized has been fascinating and of great interest, and very we all gain a lot in terms of knowledge and getting current concepts. With this in mind, I think we have put together this webinar, keeping in mind, as Dr. Nirmal rightly pointed out, that we need to cover various aspects of glaucoma, bring forward the notice of our practitioners, the concepts, at the same time the controversies, and give a balanced perspective so that we do the best for the patient and so on. We have an eminent panel. We have really a senior panel of practitioners. We also have the budding youngsters who are all raring to go. So I think to keep them under curb and maybe sort of put a cap on what is the limit to which we can go without being over exuberant is the idea of debating these topics, and not to sort of raise controversies, to bring up the controversies so that we know what is a balanced perspective at the end of the debate. Without much ado, I think let's get started, sir. Shall we go ahead with the first topic, sir?
Yeah.
I now invite the first set of speakers. We are going to first discuss about how do we diagnose glaucoma. Is a structural test the ideal way, or is the functional test the way to go? And Dr. Premnath is the head of eye department at the Chettinad Eye Hospital and Medical College at Chennai. And we also have Dr. Narayanan, who is a teacher and faculty at the Ramachandra Medical College. So we have two eminent practitioners who are going to speak to us on two perspectives of the structure, or is it function? Which is more important in glaucoma diagnosis? Dr. Premnath first.
Thank you, sir. Thank you for your kind words. Good morning, everyone, my respected seniors and my friends and colleagues. Congratulations to all of us to conduct this World Glaucoma Week. And this glaucoma controversy is a part of that, which can obviously educate our junior colleagues to have a better perspective of glaucoma. Today, my topic is on structural test in glaucoma diagnosis. The next 6 minutes, I would be discussing the importance of structural test in glaucoma diagnosis. So as you all know, glaucoma is a neurodegenerative disease of the optic nerve, results in death of retinal ganglion cells and axons. So the diagnosis basically is based on the structural and the functional abnormalities. So I am going to talk about the structural abnormalities. The characteristic structural changes in glaucoma are following: cupping of the optic disc, localized neuroretinal thinning, peripapillary atrophy, RNFL defects. Less important factors are barring of blood vessels, vascular diameter irregularity, nasalization of major blood vessels. In finding these structural changes, we have the following structural tests. So there is nothing much to elaborate on clinical assessment of ONH, because everyone know it is the gold standard method of assessment of optic nerve. It is a time-tested method. The next is optic nerve photography. So it has been on since 4 or 5 decades. And the other 3 are basically based on machines: optical coherence tomography, scanning laser polarimetry, and confocal scanning laser ophthalmoscopy. The last 3 based on the automated quantification of the structures. So clinical assessment of ONH, every clinician, every glaucoma specialist will know the importance of this. This is a gold standard method. So there is nothing more important than a meticulous disc diagram at every visit of the glaucoma patient or any patient coming for the screening. So any subtle changes in the disc can be very well picked up with the meticulous clinical assessment of optic nerve head. Next comes the optic nerve photography. So optic nerve photography, it has been proved by various studies that at least 6 years earlier, it picks up the RNFL defects and cupping of the optic disc. So though the studies are quite old, but yes, optic nerve photography has been in practice since at least 2-3 decades. In a study where they have found out that at least 60% of the eyes had RNFL defects at least 5 to 6 years earlier than they showed the visual field defects. And increased cupping, so out of 29 eyes, so the 23 out of 29 is a good percentage. So they have showed increased cupping that preceded the visual field defects. So that means it shows the importance of looking into the structural defects in glaucoma. So next comes the ocular optical coherence tomography, studying the retinal nerve fiber layers. So it is based on the low coherence interferometry. So again, it is a objective method of imaging the optic nerve head. So the picture is a typical printout of a optic nerve OCT of RNFL. So this picture shows the OCT RNFL defects getting picked up by the machine far earlier than it is picked up by the visual field testing. And there are various studies, out of which these 2 studies are very important, reiterating that definitely the structural changes could be picked up much earlier than the functional changes, that is visual field defects. So next is HRT, that is based on the lights which gets filtered by through a confocal pinhole. So this typical printout of HRT, which is based on scanning laser light ophthalmoscopy. So these studies definitely point out that the visual field defects are picked up much later than what the HRT picked up the structural defects. Next is scanning laser polarimetry. Scanning laser polarimetry is basically bifringence of polarized light to determine the tissue thickness at the various levels of optic nerve head. So this is a printout of GDX with variable corneal compensation. So it picks up the structural changes. It shows in the warm and the cold colors. So basically, all these tests are objective, and they give a printout that does not depend on the patient's performance or any subtle media opacities or the mood of the patient or the IQ of the patient. So basically, we just have to take the good quality picture, and then it gives a printout, and anybody can, any trained personnel, not necessarily an ophthalmologist, any trained personnel can take this objective test and then give a printout, and the glaucoma specialist can work on it. And it definitely precedes the functional changes, and obviously it is precise with the upcoming technologies, improvement in the technologies and the optics. Obviously, it is becoming more precise when compared to other subjective tests. In future, yes, we have apart from the other 3 structural test, we have a ganglion cell analysis, which gives ganglion cell inner plexiform layer and the ganglion cell complex. This picture shows the picking up of ganglion cell complex. Chronologically from 2013 to 2015. Next one is basically the optical coherence tomography, giving a Burke's membrane opening and a minimum rim width. So this picture shows this Bruch's membrane opening. This is a Bruch's membrane opening, and this is the minimum rim width. So basically, this gives a comparison of with the ganglion cell, generalized ganglion cell complex with the minimum rim width, and this minimum rim width is a definitive factor in picking up structural change in cases of particularly early glaucoma. So basically, the main point to reiterate is picking up glaucoma as early as possible is very important. So when it becomes 0.8, 0.9 cupping, obviously all the tests will pick up. So basically, this debate is based on picking up as early as possible so that none of the glaucoma patients are missed without any proper management. Yeah, next one is RNFL reflectance. This is again an objective test. This particular picture gives different types of defects. The top left one gives a slit defect, and the top right one gives you the diffuse defects, whereas this one is a wedge defect in the bottom left, and this is edge defect. So basically, again, this is an objective test which gives the exact RNFL defects in this. The next one is a lamina cribrosa imaging. Lamina cribrosa imaging, again, it can be picturized or imaged with optical coherence tomography. In this picture, the red dots give the anterior surface and the green dots give posterior surface. And here there is a defect in the lamina cribrosa due to the increased pressure. So these are the future tests in Western countries. Already they are in vogue, or at least in the research. So they have a future, the way to go to pick up the structural defects as early as possible. And adaptive optics OCT. So again, it gives objective then picture on the lamina cribrosa. So to summarize, the structural defects are definitely getting picked up as early as possible, and it goes a long way in diagnosing glaucoma at the early stage, because picking up glaucoma early is very important. So I end my talk saying that structural tests are the best method of diagnosing glaucoma. Thank you. Thank you for the opportunity. Thank you for organizers for this wonderful meeting.
Thank you, Dr. Prem. I think you've given a very clear perspective and understanding of what are all the structural tests available today and how technology is helping us pick up early changes. And I now request Dr. Narayanan from Ramchandra Medical College to speak on the functional tests in glaucoma and why he considers them better for diagnosing glaucoma.
Thank you, sir. So you'll have to stop sharing, sir, so that I can share my screen.
Yeah, I think Dr. Premnath has to stop sharing.
Done, sir. Done, sir. Have stopped sharing, sir.
Yes.
At the end of the two talks, I'm going to request Dr. Subhashini from JIPMER. She is the HOD of the JIPMER Medical College and the Department of Ophthalmology there. She is going to give us her comments on the structure versus function, which came first, the chicken or the egg phenomenon, which was the earlier one, and how do we pick it up and so on. And finally, we go to the judges for the last word on it. Dr. Narayanan.
Sir, just a second. Is my screen visible to also?
Yeah, go ahead.
Yeah. Good morning, everybody. And at the outset, I'd like to thank Tamil Nadu Ophthalmic Association to give me this opportunity to present at the Glaucoma Controversies debate. It's an absolute honor to be presenting in front of all the stalwarts of the field of glaucoma and my teacher, LV ma'am. So I'm going to be debating on the functional tests and their role in detecting glaucoma and their look for progression. So glaucoma by definition is a chronic progressive optic neuropathy with optic nerve changes and corresponding visual field changes, where IOP is a modifiable risk factor. So the definition of glaucoma itself talks about visual field and the importance of it in its diagnosis, and to look for the visual outcomes, the functionality of the patient over a period of time. So if we are to analyze a patient who's presenting with certain risk factors, visual fields become very important in establishing a pattern of the disease and to look for progression or to manage your treatment, including setting a target IOP. Now, there's been a paradigm shift in glaucoma diagnosis, with preperimetric glaucoma being established as an entity. But do we really treat all preperimetric glaucomas, especially when the risk factors are variable? But when you look at a visual field and you look at visual field changes, especially when they correspond to the optic nerve with risk factors, you definitely treat all the patients. There are a lot of other functional tests which have also been able to help with preperimetric glaucoma with variable consistency, especially the SWAP and the FDP. And there is a change with pattern ERG, which is both transient, and the steady state ERG, which has come up in over the last decade. So the EMGT concluded that the standardized automated perimetry was superior to serial disc imaging in detecting progression in glaucoma patient. There was a little variability in interpreting these results, but they found that stereopsis and intersubject variability in imaging the optic disc were findings in their study. They also found that both the OHTS and the EMGT had disagreements between the functional and the structural tests. In fact, we can go to the extent of saying that in the OHTS, there was a period where they found that visual field defects even appeared before disc changes. That the interpretation to that can be subjective, but these were things which we looked at. So because of the intersubject variable, interpretations could be variable on the basis of each person looking at it, and the stereopsis being a little bit of an issue, imaging of the disc can put your diagnosis at a risk. Now, there is a patient here who was treated by an ophthalmologist elsewhere. Based on the OCT, the pressures were reasonably okay. The optic nerve also did not show too many changes. On doing subsequent visual fields, the visual fields are absolutely normal through most visits. And then when we repeated the OCT, we found that the OCT was also normal in other visits. So especially when we look at the red disease, we might be over-treating. Here is a patient with a clear-cut optic nerve defect, but the OCT was variable. Though there were very minimal changes, it was missed out because the overall printout did not show a change in color. But when we did the visual fields over a period of time, we did see that there were defects which were seen. So, a green disease can also be confounding your results based on the OCT. In a country like ours, glaucoma presents at a very advanced stage. Many of the patients come with advanced cupping. So what is the role of OCT in advanced glaucoma? What is the floor effect? In advanced glaucoma, the OCT may not be able to pick up beyond a certain thickness. So how do we assess progression at that portion? It becomes, we have to go back to visual fields, or visual field monitoring over a period of time becomes extremely essential in advanced glaucoma. These are some of the other confounders which can confound our interpretation of OCT, like a posterior vitreous detachment, presence of an ERM, even dry eyes can artificially make us believe that there could be a defect when there is none, or make us believe that we are not actually seeing a defect. That again, especially in a country like ours where glaucoma is presents to us with advanced cataract, media opacities can confound results. In fact, one of the OCTs which Sir had shown also, there was a media opacity right in the front which looked at like an RNFL defect. So there are many chances that we might miss out on the results, and just if we purely go by the interpretation that is given by the objective test of the OCT without actually being able to interpret it, and that there is a learning curve to that also. That apart, operator-dependent artifacts, truncation of the acquired SD-OCT can also confound our results. A lot of times we have noticed that myopia may present with glaucoma, and it requires an OCT or can be very difficult to perform in a patient with even a pallor or myopia or disc anomalies, because centration can be very difficult and the normative data may also change in this. So visual fields can help with those, and we have to interpret our results with caution. Over the last decade, there has been a shift towards picking up early glaucoma, and ERG is an essential functional test. In fact, in a study where pattern ERG was looked at as in early glaucoma as an indicator for progression of ocular hypertension towards glaucoma, we found that ERG was able to pick up many patients who were progressing from ocular hypertension to glaucoma. There's also been comparisons between pattern ERG and OCT parameters, especially in POAG patients and those with ocular hypertension. And also these results have been compared very recently as of last year between OCT angio and pattern ERG. And we've seen that it can pick up early defects or early changes much earlier before even the optic nerve head changes start to progress. So if we are looking at them at an overall period. So to conclude, I'd like to say that what came first, the chicken or the egg? So functional tests are essential to make a diagnosis and to monitor progression. It is essential in patient education, maintaining a quality of life and care for the patient so that we're not over-treating the patient with drugs, especially on patients who may or may not need treatment or may only need close follow-up. And newer modalities, including pattern ERG, which are functional tests, may have a role in early glaucoma. But the question always exists, what is function without structure? And what is structure that serves no function? Thank you.
So Narayanan, you say that you vote for the chicken, you don't want the egg.
It's always the chicken or the eggs. So
you're also saying that red is dead and green is mean and you're floored by the OCT.
Yes.
Very interesting concepts. And I'm going to ask Dr. Subhashini to comment on this. And Dr. Subhashini, why is it that the field changes are not picking up early glaucoma? And is it always true that structural changes always precede functional tests? I think we have some studies which tell us that maybe the structure can come, the function can come in earlier and so on. So your comment and then Dr. RK's comments.
Yes, sir. So actually speaking, we know that glaucoma is a disease where there is ganglion cell loss. So these ganglion cell loss is picked up early by the structural tests like OCT. So it's like, I feel OCT and fields are like both are eyes. So they are an integral part of the glaucoma workup. And there are situations when fields actually the defects happen only when it's said that 35 to 40% of the nerve fibers have to be lost. So if you have seen that continuum, that photograph of Dr. Robert Weinberg, so where those the nerve fiber defects, there is a stage where there's nothing is detectable when the apoptosis happens. And then there is a stage when the nerve fiber defects occur and they are picked up by the OCT first. Definitely OCT picks up first. So, and then only in the advanced in the moderate and the advanced stages, the field defects start to show up. And then, so in that stage, so in the advanced glaucoma, definitely fields have a role to play, and that is the only test that we use for follow-up and all that. So whereas for the early disease, definitely OCT plays a role, because there are sometimes you have patients, because this OCT is totally patient independent. So we are able to capture the changes. So whereas with fields, it's totally patient dependent. The patient needs to have some understanding, and there are patients who definitely they never do the test. We ourselves have seen some patients like that. In those cases, OCT plays a role. But then the disadvantages are there: the red and green disease, and with fields, the unreliability. So we can't totally ignore.
You need both.
One test. You can't prefer, one doesn't supersede the other. In early glaucoma, OCT has a role to play, and in advance, it's always fields.
Fantastic. I think Dr. RK and Dr. Vijaya, your comments, and why is it that the fields don't pick up early in many patients, and why is it that the structural tests sometimes have these fallacies, and your final comments on this? Dr. RK first, and then Dr. LV.
So thank you, Murali, and I congratulate both the speakers for the nice talk, and also Dr. Subhashini. One thing, no, we are dealing with disease which is very, very chronic optic neuropathy. Whatever the functional changes in the form of visual field defect, it's not a overnight change. They should not lose the field of vision overnight or within a short period of time. Normally, and also the world studies by Quigley and other people says that to have a demonstrable visual field defect, you must have at least 30 to 40% depth of the retinal ganglion cells. And also India is such a vast country with more than 1,150 crore population. And to diagnose glaucoma by OCT and all these things is good. Of course, in institution, we can do all the gadgets, but it's a general thing, no? Most of us cannot afford to have all these costly equipment. So both structural, of course, you should have a structural, a careful still, whatever you have so many newer advances, still a careful evaluation of the optic nerve head and retinal fibrillary is very, very important to diagnose glaucoma. And of course, we can supplement with OCT and other these things if at all possible. Then, of course, field, this functional, what normally most of us are doing is the visual field defect. Even if you have a very early paracentral scotoma or nasal stub, then of course this thing. But if you have another thing, you have to keep it in mind, the risk factors, especially family history of glaucoma or myopia, diabetes. All these things also carries a important thing in this type of diagnosing glaucoma. So all these things is a collective thing. With one thing alone, we cannot diagnose glaucoma. We have to put everything together and then we have to come to a conclusion. Then, of course, after that, the patient is treatment necessary or not, then we have to decide.
Ma'am.
Yes, Murali. Yeah.
And at the outset, I want to congratulate Dr. Ramakrishnan for bringing out such an interesting program today. And good presentation from both the speakers and good comments so far from Subhashini and RK. And I just want to add that rather re-echo, they complement each other. So whichever comes first, I think we have to have both of them as a part of the glaucoma evaluation. And what I want to emphasize is never read any of the reports in isolation. It has to be in conjunction with your clinical picture. So that brings it back to the fact that you have to look at the optic disc carefully. So more than the drawings, I would recommend now we have fundus camera available with every clinic. Everybody has access to it. Capture the disc pictures. Compare your disc picture with your visual field and the OCT. So all three together definitely will help. As Subhashini has said, mild and moderate glaucomas, OCT has become part of the glaucoma documentation and evaluation. And HRT and scanning laser polarimetry both are literally dead. So what we have is only OCT at present point of time. And GCC is part of the any OCT mission program now. With a software updation, it is available across the country in almost all machines. So the reason why you have to look at the GCC is that the central field defects also can start showing the early defects. But again, you have to look at it very carefully. There is no pre-existing macular pathology existing. Similarly, SWAP is literally dead. I think when you look at the automated perimetry, it's only the white on white. Hill on blue is they themselves has said it has no role to play in evaluation of the glaucoma. These are the few comments I want to provide. Remember, they both complement each other with your clinical examination and the documentation of the optic disc. Thank you.
Thank you, Dr. Akis, and thank you, Dr. LV, ma'am. And We will move on to the next interesting topic. We very often encounter a glaucoma patient or a patient in our practice with a raised intraocular pressure, open angles, and a normal-looking disc and normal-looking field. So, do we treat intraocular hypertension, as we call it, or do we just observe these patients, or do we, based on, is there any evidence to tell us that which patients with ocular hypertension should we treat or not? So, Dr. Satyan from Coimbatore and Satyan Nagamalai, a very active, very excellent glaucoma practitioner from Coimbatore, is going to speak on treating every ocular hypertension he sees, versus Dr. Kavita from the HOD of Arvind Eye Hospital at Pondicherry. She is going to speak to us on treating selectively. So, Dr. Satyan first.
Sir, is my screen visible, sir?
Yes, Satyan.
I thank RK sir, Krishna sir, and Murli sir for making me part of this conference webinar. So I'm here to talk about ocular hypertension treating all. So what is ocular hypertension? Anybody with any patient with intraocular pressure of more than 21 millimeters of mercury with normal optic disc and somebody has to mute, sir.
Yeah, we do have a disturbance the audio. I think I request all other participants and speakers to mute except Dr. Satyan.
So ocular hypertension is defined with the intraocular pressure of more than 21 millimeters of mercury with normal optic disc and normal visual fields, which has an incidence of around 4 to 7% in the general population. So we generally have a three-way approach. First approach is treat anybody with intraocular pressure of more than 21 millimeters of mercury. The second approach is withhold treatment until POG develops. A third approach is treating patients with moderate to high risk of developing associated with the risk factors of developing POIG. And my approach is the first approach, which is the best approach. Why? Because when you call intraocular pressure of more than 21 millimeters of mercury as abnormal, then why hesitate? And by delaying or by selectively treating or delaying the treatment, you are only delaying, not absolutely abstaining from it. In 1981 itself, Quigley said substantial loss of optic nerve fibers is needed for a visual field to change and make a diagnosis of POG. So when you start eventual treatment, the patient has already lost substantial amount of optic nerve fibers. So managing ocular hypertension can be either early preventive treatment or delaying or selective treatment. So do all of them agree? Even though quite a few didn't agree with having an early preventive treatment having a protective effect, I have a few on my side to support that, yes, early protective treatment is protective in the form of delaying or preventing the onset of open angle glaucoma. So Kavita madam is about to treat only this group of high-risk groups based on intraocular pressure, corneal thickness, vertical cup disc ratio, and she, by selectively treating, we generally ignore a significant chunk of patients with low to moderate risk factors, which significantly amounts to around 30 to 40% cumulatively. So I'm not only thinking about treating the rest other than the red zone. I am treating the whole group of ocular hypertension patients, irrespective of whether they have high, low, or moderate risk. So based on OHT study, early preventive treatment helps in 50% reduction in incidence of POIG, where in medicated group, the incidence was 4.4% compared to observation group, where it is 9.5% over the period of 5 years. And after 7.5 years of phase 1 study, when they started treating observation group, they noticed 27% reduction in incidence of POG by the end of 13 years. So early preventive treatment do prevent the incidence of POG. And mean time of developing POG was delayed by 2.7 years. In medicated group, the OHT turned into POG by 8.7 years compared to observation groups, where it turned to POG by 6th year itself. And any patient who have been told about raised pressures, and if they have a family member who has lost vision because of glaucoma, then by treating them eliminates the fear of losing vision among those patients. So I generally prefer to treat patients irrespective of their optic disc changes or visual field changes. So over a 15-year period, OST study had still showed a substantial difference in the incidence of POG between the medicated group and the observation group. And I also treat elderly and with patients with systemic disorders who are at risk of vein occlusion. And Edward et al. Took the data from the ocular hypertension treatment study and found the incidence of retinal vein occlusion is much, much higher in observation group compared to medicated group. So do play a role in early preventive treatment. And delaying treatment, Michael Cass et al. Took the data from the OST study and found out the penalty of delaying treatment. And they found 50% reduction in incidence of POG in phase 1 that reduced to 27%, but still 27% across 13 years is still much, much higher in phase 2 study. And hazard ratio of 0.42, which indicates the benefit of early treatment in phase 1, which increased to 1.06, which indicates the POG incidence is decreasing rapidly after the initiation of treatment in the observation group. And more eyes reached both glaucomatous optic disc endpoints and visual field endpoints in observation group compared to medicated groups. And 51 patients developed bilateral disease compared to 32 patients in medicated groups. And waiting is not a best public health approach because considering westernized population to our population, poor follow-up and hesitancy in undergoing investigation and treatment is much, much higher in our population. And allowing a patient with raised intraocular pressure to roam around without initiating treatment carries a risk of them developing POG, ignoring them and progressing to an advanced stage. So as I said earlier, there is a progressive ganglion cell loss, so it warrants an early treatment. And untreated patients are more likely to have a visual impairment and blindness in their lifetime. And clinicians basically believe about all these glaucoma consultants. The general ophthalmologist have a very difficult decision to make to initiate treatment for OST, whether to wait for the proof of POAG or based on intuition of impending POAG. So the same OST study, if instead of having a 20% reduction in intraocular pressure as a target intraocular pressure, if they would have kept 30% reduction, then the gap between the incidence of POG between the medicated and the observation group would have been much, much wider. So much, much bigger. So, and if you, most of them might contradict me saying that unnecessarily we are putting them on medication, resulting in ocular surface disorders and all those things. So adverse events and cost cannot be an excuse anymore because a lot of companies have come up with preservative-free medications. Even in OSTS study, they didn't find any significant adverse events in medicated group. And with the advent of, with availability of generics, cost of medication is might be much less compared to years of investigation to prove POAG. So if you're still hesitant about medication, and an unpublished Arvind Coimbatore study about SLT indicates a significant drop of intraocular pressure from 22.49 millimeters of mercury at baseline to around 17.67 by the end of 1 year, which is very, with the effect is very comparable with the POAG. And this, they also found out a similar effect both in a treated OST patients and in a navy eyes with OST. So finally,
திமுகலாம் நீ என்ன பண்ற நம்ம குடோன்ல இருக்கிற பருத்தி முட்டை எடுத்துட்டு போய் நம்ம பண்ணை வீட்ல வச்சிரு. சரி வாஜரா. பேயே திமுகல பண்ணை வீட்ல வைக்கிற பருத்தி முட்டை எடுத்துட்டு போய் நீ தென்னந்தோப்புல வச்சிரு. சரி வாஜரா. மண்ட கசாயம் தென்னந்தோப்புல வச்ச பருத்தி முட்டை எடுத்துட்டு வந்து மறுபடியும் நம்ம குடோன்லயே வச்சிரு. கிளம்பு. சார் இதுக்கு பருத்தி முட்டை பேசாம குடோன்லயே இருக்கலாமே. இருக்கலாம். இவங்களுக்கு குடுக்குற சம்பளத்துக்கு என்ன வேலை வாங்குறதுனே தெரியலையே. அதான் நீங்க வாங்க ஹோட்டலுக்கார.
Various high-tech tools, people keep moving around between hospitals, and finally we treat with years of investigation. So my advocacy is to treat all and early. Thank you. Thank you very much.
Satyan, you're going to keep all ophthalmologists busy, and I think all glaucoma specialists are going to be super busy, and all the pharma companies are going to be thrilled with you. So I think if you treat all ocular hypertension, and everybody becomes 20.5 to 21. So, Kavita, what do you have to say for this?
Sir, Dr. Satyan, can you please stop sharing your screen?
I did, madam. I did, madam.
So we have listened to Satyan's perspective of ocular hypertension treatment study. Now we will see the real story, what it is. So I'm not able to share.
Yeah.
Maybe close.
Satyan has something.
The only way to win the debate is not allowing madam to talk.
Sachin, if you don't mind, I have a small suggestion. I'm much elder to you. I can do that.
Yes, ma'am.
I didn't understand what those film clips has said, but usually in a scientific forum, they are taken with a, I mean, it's not in a good taste.
Okay, ma'am. Sorry.
Saying that.
Okay, I can change it and I will remove it. Thank you.
Yes, Kavita, slide is visible. Kavita?
Sir, am I audible?
Yes.
Lights visible?
Yes, screen is seen.
Audible and visible.
Thank you, sir. So we have listened to Dr. Satyan's perspective of ocular hypertension treatment study. Let's see what is the real story of ocular hypertension treatment study.
Slides are not moving.
Are my slides visible now?
Yes, Kavita.
Yes.
Yeah. So ocular hypertension treatment study, as we all know, is one of the largest multi-center randomized controlled trial, which involved 1636 patients and followed up over a period of 5 years. The inclusion criteria is as shown here. Basically, the investigators wanted to find whether medical treatment will prevent the development of glaucoma. So they basically randomized the patient either observation or towards medical treatment with the target intraocular pressure of less than 20% below the baseline or less than 24 millimeters of mercury. So at the end of 5 years, they found the conversion rate of ocular hypertension to primary open-angle glaucoma was 4.4% in the medication group and 9.5% in the observation group. We can see here, as pointed out by my dear friend Dr. Satyan, this is the observation group and this is the medication group. There is real huge difference with 20% reduction in the intraocular pressure. The incidence of conversion to glaucoma reduced by almost 50%. So they said that medical treatment was effective in delaying or preventing the onset of primary open-angle glaucoma. But please don't get carried away by this graph by like my friend Dr. Satyan. Let's see what are all the real nuances inside that. Even the investigators were not happy with this statement, lowering IOP reduces progression to primary open-angle glaucoma. There were many unanswered questions in the ocular hypertension treatment trial. When to start treatment, whether all patients should receive early intervention. They also wanted to find out whether there is any penalty for delaying the treatment. So they continued the phase 2, which is the follow-up study of Botsman, with an average follow-up period of 13 years. What they did was they started treatment even in the observation group, and they call it as delayed treatment group. Here we can again see the graph. Once the medications were started at 7.5 years, even in the observation group, the conversion to primary open-angle glaucoma rapidly decreased and approached towards the levels of medication group. But at 13 years, the probability of primary open-angle glaucoma, as highlighted by Dr. Satyan, was 22% in observation group and 16% in the medication group. Also, the years to develop glaucoma was different between the two groups. It was 6 years in observation and 8.7% in medication group. Though there was a benefit of 2.7 years we have to observe that there was no evidence to show the increased severity of primary open-angle glaucoma by delaying the treatment. Also, in order to understand the finer details, who will benefit from treatment, they divided the population into 3 risk categories as shown here. This is low risk, moderate risk, and the highest risk, and the percentages of developing glaucoma chances are shown here. We can see in the low risk category, absolutely there is no difference between the treatment and the observation group. Whereas in the high risk category, we can see a huge gap, the difference in both the groups. The corresponding percentages are shown here. This is the low risk category, and also this is the high risk category. Also, we have to note the number needed to treat, NNT, which is 98 for the low risk category, which means in order to prevent the conversion of one ocular hypertensive to primary open-angle glaucoma, over a period of 13 years, we have to treat 98 ocular hypertensives, which is not practical and not sensible, isn't it? But at the same time, if you take the third tertile, that is the highest risk group, it is only 7, which is very much sensible, and it is easy to treat this group and this number of patients. So, early medical treatment did reduce the cumulative risk of primary open-angle glaucoma. However, absolute effect of the treatment was greatest in the high-risk group, but minimal in the low-risk group. However, longitudinal visual field data indicated that starting treatment at the diagnosis, that is, delaying the treatment, did not have any major negative impact on the subsequent course of the disease. As highlighted by Dr. Satyam, he has already showed the central corneal thickness is protective. And see this group of patients who had a thicker cornea, the same amount of presenting vertical cup disc ratio, the risk reduces from 22% to 8% here. And then again with the same baseline intraocular pressure, you can see what happens in the thinner cornea and thicker cornea. Here it is 36% and here it is 6%. And Oates came out that central corneal thickness is a very important and independent risk factor after adjusting for even baseline intraocular pressure and presenting cup disc ratio. So another paper came out assessing the hazard ratios based on these various risk factors as shown here and highlighted here. And also we have to understand what happened to the patients who were observed and what happened to the patients who were treated. We can see the probability of the cataract and the incidence of lens opacities and the need for the combined surgery was significantly higher in the medication group versus the medication group. And also we have to understand, in case if we have to treat all, is it cost effective? So they did a cost effective analysis. They divided and made 4 models. This is treat no one, treat more than or equal to 5%, treat more than or equal to 2%, and treat everyone. Okay, and this is the line showing the incremental cost effectiveness. As these points are away and steeper away from the x-axis, it means the incremental cost effectiveness becomes broader. We can see the line connecting here is not even connecting to the point which is lying on the northeast corner of this graph, indicating that it had no meaningful associated incremental cost effectiveness ratio. That means it is cost more and the effectivity is less. Hence, we have to treat selectively. So, and also when you looked at the patients who were observed, when they underwent cataract surgery, we can see here a significant drop in the intraocular pressure, which was maintained over a period of 3 years. And we can see here the highest percentage of pressure reduction was seen in patients with highest preoperative intraocular pressure. So, who are all the patients at risk who can get converted to primary open-angle glaucoma? Older age, higher intraocular pressure, larger vertical cup to disc ratios, higher pattern standard deviation, and also thinner CCT values. So we have to bear in mind the patient in front of us, his age, life expectancy, affordability, availability of the medication, and also adverse effects. See, we all admire Aishwarya Rai and we would like to have beautiful eyes like her. But what happens if we start treating everyone? See, the dews, periorbital pigmentation, periorbitopathy, ulcerations, and whatnot. So I am sure that the panel of eminent judges are with me and will agree that clinicians should consider initiating treatment for individuals who are at moderate or high risk of developing primary open-angle glaucoma. Thank you. Thanks for the opportunity.
Dr. Kavita, I liked your animation and thing of converting Aishwarya Rai's for side effects of glaucoma medication. Very nice. The long eyelashes and the changes around the eye. I think very useful to convey to patients that this is what will happen to you if you apply eye drops or go for surgery and so on. So a nice concept, and I think very interesting debate that both the speakers have spoken well. I'm going to ask Dr. Nagalakshmi to comment on this. She is an eminent glaucoma practitioner in Chennai and my colleague at MNI Hospital. So what is your take on, do you treat everybody, and what should be the correct way to manage this?
A very good morning to everybody. I would first like to thank TNOA, RK sir and Murli sir for giving me this opportunity to share the platform with some of the most eminent glaucomatologists and my teachers and mentors here. So both of them, Dr. Satyan sir and Kavita ma'am, had beautifully outlined why and why not we should treat. So my take on this is any treatment, there should be a balance between risk and benefit. So the OHTS would be the landmark study to look up to see which patients are at higher risk and why we should treat them, or the patients who we should observe. So quality of life, cost effectiveness does play an important role when we think about treating these patients. So definitely, if we are going to treat all the OHTS patients, it might not be very cost effective. The quality of life in terms of ocular surface diseases would be a problem. But at the same time, we'll have to keep in mind the risk factors like what Kavita ma'am had outlined, and the OHTS study also shows us, which is thin corneal, central corneal thickness, increased vertical cup to disc ratio, a pattern standard deviation, which is on the higher side, and at the same time, we should also look into factors like if the patients would be ready for regular follow-ups. So putting all the parameters in place, we can decide whether it will be really useful in treating these patients, or it's wise to observe them.
Dr. Moideen from Arvind Tirunelveli is here, and he's going to give us, does he treat everybody with intraocular pressure more than 21 at Tirunelveli?
I think it'll depend upon how you measure IOP. You go by NCT or go by accumulation. Also, I think you rule out goniotrope. It's very important. Most of us don't do goniotrope. Just angle glaucoma. I think keeping this perspective, anybody with a family history glaucoma, I think less CCT, a 1/8 patient, and preferably more than 30, who like to, the people attempt to treat as relative. Also look at the side effect of anti-glaucoma medication as given by Kavita. I think it keeps this in this scenario. Certainly some of the condition people who treat OHTC, or normally I think both Kavita and I think Satyan will treat selectively. Thank you.
Dr. Murli, can I make a comment?
Yeah, we'll go into the comments at the end of the panel discussion. Dr. RK to comment.
Yeah, first of all, I have to congratulate Dr. Satyan and Kavita for the wonderful debate. Really, it's very nice. I enjoyed it. And Satyan also, in his presentation, he has convinced us. Now I am in doubt whether to treat all ocular hypertension or not. One thing he told, so to eliminate the fear of losing vision. Satyan, very nice way of presentation.
Sir, but thanks.
I like that sentence. And also, he has one more thing he pointed out, the fear of venous occlusion in cases with ocular hypertension. But even though it is there, as already all pointed by other speakers and other things, so glaucoma is such a chronic, lifelong disease. So treating all ocular hypertension is, I don't think it's sensible, because beautifully Kavita has mentioned in her presentation, asked, but one slide, what are the cases you have to teach? That's, of course, that's one of the important take-home point in this presentation. We need not treat all cases of ocular hypertension up more than, how come a patient with an normal vision, just because of increase in intraocular pressure, we cannot treat them? Because the other end of the treatment, not only expensive, every patient, because the patient is asymptomatic. Ocular hypertension is asymptomatic. We are making them symptomatic by instituting our treatment. That's the main thing. So we have to be very, very selective only. That's what we follow, as pointed out by Kavita, old age and increased intraocular pressure, cup-disc ratio, family history, and some of the other important risk factors. Then we have to. But treating all, because many people, youngsters, may watch this postgraduates, no? So it's better to go by that only, because it's not necessary to treat all the ocular hypertension, because of course you have the progression, all the studies 16%, 24%, but the severity is not that great, as told by Kavita. So that's a thing we have to keep it in mind. So periodical follow-up is very, very important. You have to catch up the case in its early stage, whether there is any change in the functional thing, as well as the structural and functional changes in the optic nerve head and visual field. Then we have to immediately treat. Otherwise, I will go with the risk factors.
In the interest of time, I think we will move on to the third topic. It's another interesting topic of initial management of open angle glaucoma. Do we medicate first, or should we consider the SLT as an option and offer it to patients? I'm going to invite Dr. Parivadini, who is a senior consultant at Shankar Nethralaya, to speak on medical therapy for POAG versus SLT, who is going to, Dr. Premanand is going to speak on SLT as a first choice. He is from Aravind Eye Hospital, Pondicherry. So, Dr. Parivadini.
Thank you, sir. Thank you. At the outset, I would like to thank TNOA RK sir for giving me this opportunity. Are my slides visible, sir?
Yes, doctor. Yes, it's visible. Yeah.
Thank you. So I'll be speaking about starting topical medications as primary therapy for primary open angle glaucoma patients. So we know that intraocular pressure is the only known modifiable risk factor for glaucoma and its progression. So when we diagnose a patient with open angle glaucoma, when we diagnose a patient with open angle glaucoma, we are faced with the situation of whether to start them on anti-glaucoma medications or do an SLT. I will take you through these few slides to say when to start them on topical AGMs. So we now have the availability of a wide range of anti-glaucoma medications, both generics and the original molecule, to control the intraocular pressure in a population. And we have known long that even as monotherapy, these anti-glaucoma medications are able to reduce the intraocular pressure significantly. Even as a single once a day usage of prostaglandin analogs, it reduces the intraocular pressure significantly. 25 to 35% reduction in intraocular pressure is achieved. So how does this compare in efficacy to SLT? The first RCT to come out was the SLT versus the MED trial, which included 127 eyes with OHT and POAG. To be inclusive, the intraocular pressure had to be more than 24 and less than 31 millimeters of mercury in the eye with the higher pressure. And in the other eye, it had to be more than 20. So 52 eyes were randomized into the SLT and 48 in the medications group. And it was seen here that at the end of 12 months, in the SLT group, the IOP change from baseline was 6.3 millimeters of mercury. In the medication group, it was slightly higher. It was 7 millimeters of mercury. There was change observed even at 4 months, but this was not maintained at 12 months of follow-up. Both the group, the medication and the SLT group, required treatment escalations in terms of medication addition. So we have to remember that the MED versus the SLT trial included patients who were washed off on anti-glaucoma medications. In the LIGHT trial, they included treatment-naive patients. These eyes were not exposed to anti-glaucoma medications. Again, here they were randomized to SLT or the eye drops. And very briefly, they included majorly mild open angle glaucoma patients and ocular hypertensives. And at the end of 3 years, it was seen that in the SLT, 93%, and in the eye drops group, 91% of their patients achieved the target intraocular pressure. So at 3 years end, 74% of their patients in the SLT group required no drops to maintain the intraocular pressure. So what about the remaining 25%? they had to be on 1 to 4 anti-glaucoma medications to control the intraocular pressure. And moving forward, the 6-year results of the LIGHT trial, which was published recently in ophthalmology, interestingly, they had a significant number of patients retained in both the groups. Again, it showed that 72% of their patients were under control without the need for anti-glaucoma medications. 19% of their patients required anti-glaucoma medications for intraocular pressure control. So they also required repeat SLTs for intraocular pressure control, which was seen in the study. And despite the pressures being under control, achieving target intraocular pressure, they could still see disease progression from OHT to open angle glaucoma in both the drops group and the SLT group. However, progression to open angle glaucoma was a little more in the medication group. So we can see here that SLT is not uniformly effective in all our patients. Even in the repeat SLT study, which was published, showed that 25 of their eyes, when they underwent primary SLT, did not show any response, and they had to be started on topical anti-glaucoma medications rather than doing a repeat SLT. So we can see here that SLT is not effective in all our patients. And we can see early failures, which will require repeat SLT, and even late failures. So SLT will have to be repeated to control the intraocular pressure adequately. And we can see from this slide that the reduction in intraocular pressure, which we achieve with SLT, might not maintain for long. The survival analysis indicates that 50% of the eyes failed to treatment after SLT at 2 years. So the most appropriate for our population is the availability of this machine in all centers. Probably only a handful of centers in Chennai metro would have SLT machine, I think. So, and our population should not also assume a procedure like this is the end of the treatment. If you come to the cost of it, compare the cost of medications and SLT, SLT would probably require a repeat procedure, and with the added medications would almost cost similarly compared to the medication burden of our patients. And probably the minor thing is to probably convince the patients. It could be challenging to convince the patients to undergo a procedure rather than start anti-glaucoma medications. So I would like to conclude here that anti-glaucoma medications are easily available and accessible to our patients, and SLT only may not be effective. We might have to repeat the procedure or start anti-glaucoma medications. And when we compare both, they are both similarly efficacious, and both are not the only cure. Patients have to be regularly followed up. The treatment might have to be escalated during the follow-up. Because of its efficacy, when available, SLT should be the first choice. Thank you for your attention. Disclaimer, we always do SLT as the first procedure and then start anti-glaucoma medications.
You're a true politician. You always start off with a fact and then you say you have a disclaimer and then you say I do both. So I think a very interesting perspective of offering medication as SLT. It's a very common dilemma with all of us in practice phase, what to start with and which medication to use and is laser useful or not. Dr. Premanand is from Arvind, Coimbatore. And I think they've recently acquired a laser machine. So is that the reason why everybody is being offered SLT at Coimbatore is my query. And Premanand, let us know what you have to say about this.
Good morning, sir. Thank you for the kind introduction. So I'll be talking about selective laser trabeculoplasty. Once again, it's not working.
Yeah, your first slide is visible. Yeah.
Yeah. So as you all know that SLT mainly acts on the melanin pigments of the trabecular tissue, thereby release of chemical mediators, which in turn helps in remodeling the extracellular matrix, thereby increasing the aqueous humor outflow. And as far as the IOP reduction is concerned, it brings down by 20 to 25% of IOP reduction, approximately around 6 to 9 millimeters of mercury. The main advantage of SLT over the ALT is it doesn't cause any structural damage to the trabecular meshwork, so that it can be repeatable, and even mix can be possible even after an SLT. The main indications of the open angle glaucomas, be it primary or secondary, even in pseudoexfoliation pigmented glaucomas, you can do an SLT. And in angle closure glaucomas, only those selective patients where after the PA, if the angle opens up and you're able to see the trabecular meshwork, you can still try an SLT. Whereas the main contraindications are the closed angle glaucomas, any patients who have more chance to have inflammation in the eye. The few complications as well as the SLT are the transient rise in IOP after the procedure, as well as minimal inflammation, which can be controlled easily. So when do you advise? Say SLT can be advised as a primary procedure in particularly OHT and in patients with early glaucoma, as well as in patients who are planning a pregnancy where you want to avoid side effects associated with the topical medications, or as even an add-on or a replacement therapy where the patient can't afford or not complying to the eye drops or want to postpone surgery in the meantime. So as we all know that we have been treating patients with the medical management as the first line of therapy for the over several long years, and there is enough evidence in the literature to say that yes, medical management really controls IOP and helps in preventing progression. So do we have to change our practice patterns from medication being the first line of management to the SLT, and do we have the evidence to say that? So now we'll be talking about the LIGHT trial, which is a randomized control trial, which has been done across 7 UK centers, which comparing the medical management with the SLT as a primary management for OHT and primary open angle glaucomas, particularly with the mean deviation of less than -12. They included up to moderate glaucomas. However, they have included even little bit of patients with advanced glaucoma. And they have randomized 718 patients, of which at the end of 3 years, they have analyzed around 300 in both the groups. And the main outcome measures were the quality of life. Say the primary outcome were the European quality of life, or the secondary outcomes are the quality of measures, which includes the glaucoma utility index, glaucoma symptom score, and quality of life index 15 scale, as well as the safety and efficacy of the SLT and cost effectiveness of it. So at the end of 3 years, they have found that there is not much of a statistical difference between the two groups as far as the quality of life measures are concerned. However, SLT gives you a few eye drops for the control of IOP, fewer surgeries, as well as less adverse effects as compared to the anti-glaucoma medications. As well as the cost of the SLT is less when it compares to drops over the long term. And they've concluded SLT was as effective as eye drops in controlling IOP, but more cost effective as a first-line therapy. When they analyze the patients for another 3 years and they come out with the results at 6 years follow-up, which also reiterated that the quality of life measures after 6 years was same between the two groups, which is not statistically significant. And when it comes to the efficacy of the treatment, if you can see the patients who are on the drops group had more progression, let it be OHT to open angle glaucomas or progression of open angle glaucoma as such, which is statistically significant. As well as if you see the ocular surgeries that they undergo, patients on the drops group underwent more trabeculectomies at 3 years as well as at 6 years, and more phacoemulsification in compared to the SLT group, which is also statistically significant. When it comes to the safety of it, patients in the anti-glaucoma medication group had more adverse events than those in the SLT group, even though which is not statistically significant. And they concluded SLT is safe for both open angle as well as OHTs for the long-term disease control than the initial drop therapy, as well as there is a reduction in the incisional glaucoma and the cataract surgery. Coming to our experience, this is an unpublished study from our center in which we have treated 75 eyes with the OHT and POAG, and we have found a significant drop in the IOP from say a mean of 20.5 to 16.7, and there's a significant drop in the number of medications also in the groups. Whereas this was not published, whereas we have another one which is published in a TNOA journal, which is mainly on the efficacy of SLT on secondary ocular hypertension following a DALC in those patients who are medically uncontrolled after the DALC procedure, particularly on steroids. Even after shifting from Predford to Lotipred, they were still having high IOPs. Since the cornea colleagues don't want to stop them on steroids, we have no other option but to treat them. Since the medical management is not effective, we tried SLT and we have found a significant reduction in IOP with SLT in this group, and they were all mostly medication free or on minimum medication with IOP getting controlled. So now we have the evidence and it's time to change from primary medical management to primary SLT in these eyes. Thank you.
Thank you, Prem. And I now invite Dr. Chitra, Professor Chitra from the Regional Institute of Ophthalmology at Chennai, and her comments on what she would do and what is the correct way to treat these kind of patients with initial therapy, medication or laser.
Good morning, sir. I first like to thank Dr. R.K. and Dr. Murali Ariga for this opportunity. As far as this topic is concerned, I am for the drugs as the initial management for glaucoma. because now that we have effectively acting drugs like prostaglandins, which produce a reduction in IOP of about 30%, and even timolol, which causes low air, it also brings about 20% reduction in the intraocular pressure. Now, as far as SLT is concerned, the cost factor has to be taken into consideration, and the availability of the machine in the centers also plays a role. Though the trabecular damage does not happen with the SLT, sometimes repeat procedure is also required. So my vote is to start the treatment with the drugs as the first line of choice in mild glaucomas. SLT can be given as adjuvant treatment.
Thank you, Dr. Chitra. I think you really brought out a very important perspective that availability is an issue. And I think Dr. Parivedini also pointed out that we will not have the machine even in the suburbs of Chennai. So how can we offer SLT as initial treatment? And Dr. Vijaya can give our final comments on this.
Okay, thank you, Murli. I think I should congratulate both presenters for doing a good job, and they could share with the available evidence from the literature. And what is important is, I think, offering it to the treatment naive patient. So as a first line, where the eye is not exposed to any medication, if you have the SLT, we are bound to offer that option. Ethically, it is correct to offer that treatment to the patient, if you have. And once the patient understands why we are offering it, what are the limitations of the treatment, we can decide to go ahead with the treatment. Again, I want to come to the point one, like Mohiddin has said, that it is very, very important. We have to make sure that what we are dealing with is the open angle glaucomas. So for treatment naive patients, when there is a facility available, we can offer the treatment to them. There are situations where there are multiple drugs patient is on, they want to reduce the number of medications. We do offer, but we don't have sufficient data to suggest, depending upon the level of the disease, depending upon the number of the medication, how the patient is going to respond. There, the hitch is that we have to follow them up very closely to make sure SLT has benefited them. These are the two comments I thought will be useful.
Thank you, ma'am, and thank you. And I think the very clear understanding of that SLT is a good choice, provided you have it, and that SLT does work. And initially, there was some skeptical criticism about SLT not working in Indian patients and so on. So I think that has been dispelled with, and I think most of us could offer SLT provided you have the facility. And of course, in certain situations where medication is not tolerated and so on. I think with this, we will move on to the fourth topic for the discussion. We all know that the lens has been implicated as a culprit in many glaucoma patients. And especially in angle closure disease, we worry that the lens is the culprit. And despite doing YAG-PAs and so on, so we think that the lens could be a problem, and removing the lens is an option. There has been some evidence and some controversial studies which has shown us the evidence that removing the lens is primarily is a good option. And we have two speakers to tell us about this. Dr. Preeti from Aravind Eye Hospital, Chennai, is going to talk about knocking off the lens in primary angle closure and angle closure disease versus doing only a YAG-PA and doing the traditional treatment of YAG-PA and then medication. Dr. Archana from Rajan Eye Care. So Dr. Preeti first.
Good morning to all. Is my screen visible?
Yes, Preeti.
Yeah, my topic for today is lens removal for primary angle closure. Here, I would like to make it a point clear that the lens removal I'm talking about is about the visually significant cataract. So we all know about the EAGLE study, So is clear lens extraction useful in primary angle closure disease? In the EAGLE study, 805 patients were assessed for inclusion, and out of which 386 patients were ineligible or refused to participate. A large group of patients were reluctant to undergo clear lens extraction. Here in this study, primary angle closure and angle closure glaucoma patients were combined, and the mean postoperative intraocular pressure was only 1.18 millimeters lower in the clear lens extraction group.
The slide is not moving.
Yeah, could you go to screen show and then start moving?
Yeah.
Preeti?
Go to screen show.
Is it moving now, sir?
No, it's still in the first slide.
Screen show.
Is it not moving now?
Yeah, you should stop.
Yeah.
Try again.
Yeah.
Reshare screen.
Is it seen now?
Yeah.
Yeah, please go ahead now. Yeah.
No, it's not moving.
Just click the mouse. Click the mouse.
Yeah, now is it seen, sir?
Yeah, please go ahead. Yeah, go ahead. I think I can see CLE in primary angle closure disease.
Yes, sir. Yes, sir. So the mean postoperative intraocular pressure was only 1.18 millimeters lower in the clear lens extraction group at 3-year follow-up. And visual field deterioration did not differ significantly. And there was a lot of missing data on synovial angle closure from large number of patients. Hence, the role of clear lens extraction in primary angle closure disease awaits further research. Now, is my next screen visible?
Yeah, reduction in IOP.
Yeah, reduction in. So now I would like to discuss the role of lens removal in primary angle closure under 6 headings. The first being the reduction in IOP. A meta-analysis of 32 studies done from 1997 to 2017 showed that the intraocular pressure reduction from the baseline after cataract surgery was about 6.4 millimeters of mercury in angle closure glaucoma and 2.7 millimeters of mercury in open angle glaucoma. And a study on comparison between phacoemulsification versus phacotrabeculectomy in medically controlled primary angle closure glaucoma with cataract says that 78% of eyes in phacotrabeculectomy group and 80% of eyes in phaco group had intraocular pressure control without anti-glaucoma medication at the end of 1 year. And this again reduced to 52% in phacotrabeculectomy group and 59% in the phaco group at the end of 5 years. So the more rapid visual recovery, similar IOP control, and similar visual field stability favor phacoemulsification over phacotrabeculectomy in medically controlled PACG eyes with cataract. Here I'm specifying that it's medically controlled primary angle closure eyes with cataract. And the next study on phacoemulsification versus combined phacotrabeculectomy in medically uncontrolled chronic angle closure glaucoma with cataracts states that the combined phacotrabeculectomy with adjunctive mitomycin group had significantly more postoperative complications than the phaco alone group. So these are all the mechanisms that causes reduction in IOP after cataract surgery. The first being deepening of the anterior chamber with viscoelastic and hydrostatic pressure surgery mechanically will strip open the pars, the peripheral anterior synechiae, and irrigation during phaco will flesh open the trabecular meshwork, and cataract extraction deepens the anterior chamber, opens the angle, and increases the aqueous outflow facility. And the release of prostaglandins, interleukins, and TNF also improve the aqueous outflow. Increase in uveoscleral outflow by alterations in the blood aqueous barrier also happens. In the bag IOL would stretch the zonules and will cause traction on the trabecular meshwork and would open up the trabecular spaces. Now coming to the second heading, which is opening of the anterior chamber angle. A study on long-term effects of the mild cataract extraction versus laser peripheral iridotomy on anterior chamber morphology in primary angle closure suspect eyes showed that when compared with LPI, laser peripheral iridotomy, lens extraction achieved a wider angle with no residual angle closure. Hence, lens extraction could be considered as a preferred intervention in patients with primary angle closure suspect with cataract, especially in angle closure by mixed mechanisms. So again, the opening up of anterior chamber angle shows that is helped by cataract extraction that results in opening of the anterior chamber angle than the laser peripheral iridotomy is also measured by the TICV on UBM. So further anatomical support is there to show that cataract extraction is effective in the treatment of primary angle closure. So next, coming on to the role of crystalline lens in primary angle closure disease. We all know about the lens vault and the relative lens vault. Lens vault is a perpendicular distance between the anterior pole of the crystalline lens and the horizontal line joining the scleral spur. And relative lens vault is lens vault divided by the AV. So the increase in lens vault and relative lens vault both are risk factors for primary angle closure and primary angle closure glaucoma. Here there is a comparison of biometric parameters between the angle closure and normal control groups. This shows that the lens vault being higher in angle closure compared to the normal controls. So increased thickness and the bulk of the lens anterior to the plane of the scleral spur pushes the peripheral iris against the trabecular meshwork, and this will worsen the angle crowding. Now coming on to the plateau iris syndrome and the combined mechanisms. Laser peripheral iridotomy does not open up all the angle in eyes, especially with non-pupillary block mechanisms such as plateau iris and combined mechanisms. So more than 30% of plateau iris has been detected on UBM in the presence of a patent PI. And in a study, they have found that by UBM, 60% of eyes had persistent appositional angle closure, at least in one quadrant after LPI. So primary angle closure disease post-PI shows a large anteriorly placed ciliary process and a narrow ciliary sulcus, which was found in 9 of 22 eyes in open angle and 22 of the 33 eyes in narrow angles. So I feel these are all the disadvantages of YAG laser peripheral iridotomy, which includes a transient increase in intraocular pressure, hyphema, visual dysphotopsias, cataract progression due to the damage, direct damage to the crystalline lens, altered aqueous fluid dynamics, and iridotomy closure is possible and which would necessitate a repeat LPI. And prevalence of primary angle closure disease. Primary angle closure suspect is around 7.24%, primary angle closure is around 2.75%, and primary angle closure glaucoma is around 0.88%. By 2040, 111.8 million of people would be affected with glaucoma, which would disproportionately affect Asia and Africa. In Asia, 53.4% of primary open angle glaucoma and 76.7% of primary angle closure glaucoma. Primary angle closure glaucoma causes significantly more blindness than primary open angle glaucoma. So a single definitive treatment with reliable long-term outcome is very important at this junction. So the following factors favor cataract surgery in primary angle closure suspect, primary angle closure, and medically controlled primary angle closure glaucoma with visually significant cataract. Those factors are the better reduction in IOP, opening up of the anterior chamber angle, the role of crystalline lens in primary angle closure disease, the plateau iris syndrome and mixed mechanisms, and YAG laser peripheral iridotomy not completely innocuous, and the prevalence of primary angle closure disease and need for definitive treatment. Thank you.
Dr. Archana from Rajan Eye Care at Chennai is an eminent glaucoma practitioner, and she will give us an idea of why she would do YAG-PI first and medicate and not think of removing a lens, especially if it's a clear lens.
My screen, is it visible, sir? Am I audible?
Yeah, you heard, but your slides are not yet come. Yeah.
Is it on?
I think you're yet to share.
Is that come, sir? I think there's a slight delay.
No, it's not shared.
Now, sir? Because I am able to see it here.
You
can probably log out and come back again.
Close it and open. You have to go to share screen.
Good morning, Dr. Sujata.
Yes, I think now it's seen.
Yes.
So I have a slightly different take on the topic. So I'm going to limit my talk to managing primary angle closure with a YAG laser iridotomy.
Oh, yeah, that's it.
So to be clear, primary angle closure by definition is appositional angle closure of more than 180 degrees in the presence of synechiae and or an increase in intraocular pressure. The condition also means that there is no optic nerve head damage or a visual field defect. So to properly evaluate the disc, the first step is dilatation. So by doing that in a primary angle closure patient, we always have the risk of precipitating a pupillary block and an acute angle closure attack. We know that the risk in PACS patients is relatively less as evidenced in the ZAP trial, but the actual data on PAC eyes is lacking. So an undilated disc evaluation has its own shortcomings. It's often cursory, and it is impossible in hazy media or in small pupil. So that very much questions our diagnosis, whether we are dealing with PAC eyes or eyes with glaucoma. So why do a PI in patients with clear lens? Well, it helps us to dilate the eyes safely and to evaluate the optic nerve head in detail without risking an acute angle closure. And there can be an argument saying that we can always perform tests like fields and scan and find out if there is significant glaucoma. Well, if they turn out abnormal, again, we are back to square one because any investigation has to be correlated clinically. And in the presence of optic nerve head damage, our management is going to be slightly different. It's going to be more proactive. And also in some patients, it's very important that we dilate and see the posterior segment, especially if they are at risk. Coming to why do a PAC in a patient with cataract? Why do I have to do a PI first and then again a cataract surgery? Well, it gives us time to control the intraocular pressure better before extracting the lens. And it also helps us to evaluate vital factors like pupillary dilatation, zonular weakness, which are not expected in these eyes, which are not unexpected in these eyes. And this helps us to plan our surgery better. So nowadays, patients do not ask us whether we can remove the cataract and place the lens. They ask us more demanding questions like, how long should I take rest? When will I start seeing better? And so on and so forth. So to give a realistic prognosis to the patient and the attender, I think we have to evaluate the cataract in a detailed manner. So coming to the advantages of iridotomy, everybody knows it's easy and relatively straightforward. The complications that are quoted are often minor and self-limiting, like inflammation, glare, and bleeding. Rarely, peripheral cortical cataract has also been reported. And definitely, it is cheaper than cataract surgery. And the learning curve involved is small, and it can easily be learned and taught and widely practiced. And there is also evidence that peripheral iridotomy has place. I would like to just quickly quote two studies. One which was done by Pandav et al., which included 43 Indian eyes, and they reported that 80% of PAC eyes did not progress after a PI. Therefore, PI favorably alters the natural course of primary angle closure disease and reduces burden of blindness due to it. Also, another study by Radhakrishnan et al., which is like a review of literature of publications till 2017, which showed that PI increases the angle width both by gonioscopy as well as by image the stages of primary angle closure with a good safety profile. Though most PAC eyes do not need further intervention, many PAC eyes did receive intervention. However, progression to primary angle closure glaucoma is uncommon in PAC after they receive a PI. So, talking about the elephant in the room, the EAGLE study. So this study talks about the effectiveness of early lens extraction for the treatment of primary angle closure glaucoma. They concluded that clear lens extraction has clear advantages over a PI in terms of health status, intraocular pressure control, and cost effectiveness, and so on. Well, but we have to look at the data more carefully. So EAGLE is not a worldwide study. It includes patients who are mostly from the United Kingdom, and a handful of them from centers from Malaysia, Singapore, did not include any center in India. And out of the 800 patients, only 400 patients refused to be part of the study, as already pointed out. So the acceptance of asymptomatic patients for a procedure, especially a clear lens extraction, is questionable. Also, patients were not masked. When they answered the questionnaire, they knew whether they had undergone a PA or a cataract extraction. The mean difference in intraocular pressure was just 1.18 millimeter mercury, which might not have clinically significant impact in primary angle closure eyes. And yes, we all know that every millimeter mercury counts, but that is only in advanced glaucoma. And in the EAGLE study, patients who had advanced glaucoma were excluded. Also, the reported cost effectiveness is in United Kingdom. This might not be applicable in our country. The functional questionnaire, which touts there's a better outcome, it probably reflects the better refractive outcome in patients who had undergone a phacoemulsification. It might not equate to glaucoma control. And the more additional procedure that was quoted to be received in patients who had undergone a PI was cataract extraction in 70% of the cases, which at the end of 3 years is expected. And also the study does not talk about various other important things like what was the endothelial loss like in the phaco group versus the PI group. And another important point that I would like to point out is lens extraction has been suggested only for PAC eyes who had an intraocular pressure more than 13 millimeter mercury, which is a very minor number of patients that we deal with. And also it is incomplete. My talk will be incomplete if I do not talk about the risk involved in doing a cataract surgery in PAC eyes. Yes, phacoemulsification has evolved, but still cataract surgery in shallow anterior chamber is not a routine surgery. There is always more risk of complications like PCR, endothelial loss, nucleus drop, and sudden choroidal expansion. So it has been recommended that cataract surgery be performed by experienced surgeons in centers with facility for a corneal transplant and VR surgery. So I would just like to ask questions to my colleagues. So if you had primary angle closure with high IOP, would you rather undergo a PI or a phacoemulsification? The illustrations would probably, make us decide to go for a PI. So in conclusion, managing PAC is definitely not straightforward. While the cataract surgeons in us are tempted to take out the lens, explaining the risk involved to the patient is every caregiver's duty. So I'd like to point out to this infographic. So studies, they evaluate the benefits and risks for the general population. The provider will evaluate the benefit and risk for his particular patient, and the patient evaluates the benefits and risk in terms of his own personal values. So decision-making in science, in medicine is still an art. PI is still the standard of care for majority of primary angle closure patients in our practice. Thank you.
Excellent presentation by both of you. I think fantastic talks and very clear and understanding of both the concepts. I think we have Dr. Sujata Mohan here, and she's very unique ophthalmologist in the sense she's a cornea specialist. She does everything in the cornea. She replaces the cornea, does refractive surgery. She's an amazing cataract surgeon, and she's a glaucoma specialist. So why is she scared of taking out the lens, all clear lenses, whomever she is with angle closure disease? Your comments, Dr. Sujata.
Thanks, Murli, and I'd like to thank Dr. RK for giving me this opportunity. I don't know whether I'm accepted as a glaucomatologist, but anyway, I've been...
You are, no doubt about it.
Thank you. Thank you. So it's a very difficult question to answer because I think when there is cataract, most of us would shift towards doing cataract extraction in the first go, when there's significant cataract. The question arises only when there is very early cataract changes, the patient is young, and whether we are going to do a YAG PI or a cataract surgery. So again, I think this has to be discussed at length with the patient. I would definitely go for YAG PI as a first choice if there is no cataract. But in the presence of cataract, I would definitely, particularly significant cataract, then my decision would be to go for a cataract surgery. But there are some points, there are some patients who are neither here nor there, just very early cataract changes, and still they are young, around 50s. So would I go for a cataract surgery? Then I would discuss the options with them. Definitely, yes. Like Archana said, it will be nice if I can dilate them and see, and then decide about the cataract surgery. But in some patients, we may not be able to do that, particularly if the patient we are suspecting also has some retinal issues, So all these patients, I think, in the group which lies between cataract and no cataract and a slightly higher, older age group, then maybe my tendency would be to discuss this with the patient and decide more in favor of a PI. Because then if there is not much cataract, you can do a PI, dilate, see the retina, and then give the prognosis regarding cataract surgery. But if there is significant cataract and we really know that that is going to help the patient, we'll go ahead and do the cataract surgery in the first instance, not do the laser, because that is one step the patient can avoid. As a person who has undergone YAG PI, I'll tell you, it is not painless. It is quite traumatic to the patient. So it's not, I would say phaco surgery is not so traumatic. It is very traumatic to the patient because I could feel the pulse, the rocking pulse at the back. And so you really have to think twice. If there is one way of avoiding this and going directly for cataract surgery, yes, I would do it. And don't get frightened by Archana's corneal edema case. That is very, very...
It doesn't happen to you.
It doesn't happen to me.
It doesn't happen in your hands.
All of us have very good surgical hands, and only good surgeons would opt to do that first instead of going in for a PI. So I'm sure that is just an hyperbole she has put up. I think it's entirely, like she said, the decision I'm making has to be done patient to patient and discussed with the patient previously. But if there is a chance a patient has a retinal problem or retinal issues and not able to correlate the cataract with the vision, then a PI should be done first and then dilate and see and then decide the next course of action.
RK, sir.
Yeah. Roni is there. You can ask Roni. You will be a better person to answer. Roni,
I think he has joined. Yeah, he's joined. Yes.
Yeah.
So thank you, sir, for the invitation. And so this is always a slightly debatable topic. But what I appreciated was the question at the end, that if you had a narrow angle, what would you like? And I've actually been thinking of that for the last few minutes. And I think personally, I would prefer to have a YAG PI done, because a smaller intervention is better than a larger intervention. Having said that, if there is any significant, marginally significant cataract, that's a valid option to take the lens out. But we have so many patients with narrow angles whom we have followed up for 1.5 to 2 decades before they required a cataract surgery. And at a slightly younger age group, accommodation does make a difference. So I think both speakers presented their case pretty well, but that last clinching question forces all of us to introspect and see what we do. Of course, Dr. Sujata says she's undergone the procedure and it wasn't very comfortable. So
when it comes to yourself, you would play it safe.
I'd play it safe. I mean, if I have narrow angles with high pressure, I would get a YAG PI done.
Absolutely. I think playing it safe for our patients is the most important priority. I think all of us are here for that perspective, for that thing alone, that we have to do the best for our patients, and all of us are here to discuss various aspects, keeping in mind the patient interest as first. Patient comes first for all of us. I think thank you all, and I think you've really given us wonderful comments.
Yes,
ma'am. Yes, ma'am.
Yeah, no. I think what we have to remember is it is a spectrum. PSC's approach will be totally different with the PSC and PSCG. So we have sufficient evidence to say there is no need to do the PA for all PSCS patients. We have to be very selective, and this is some knowledge that has changed our treatment modalities over a period of time. If you have only narrow angle, there is no need to rush in for the iridotomy. If you want to dilate them, you can dilate them, give tablet Diamox, dilate them, examine them, use only tropicamide, no need to put tropicamide with phenylephrine, give Diamox, and if you want, you can do dilatation one eye at a time, examine, make sure there is no retinal pathology, ask the patient to come back. So there is no need to do the YAG PA for all the PSCS patients. Thank you.
Thank you, ma'am. Thank you, ma'am. I think we will move on to the next interesting topic for debate today. The new MIGs has caught us all by surprise, and I think there are so many MIGs available. And what we should try to understand is, should we do the GAT procedures which involve 360 degrees, something like the suture GAT, or should you do limited procedures in the nasal angle like the KDB or the eye stent and something like that? So understanding MIGS and choosing the correct kind of so-called minimally invasive glaucoma surgery for a mild to moderate glaucoma, I think I invite Dr. Madhavi from Arvind Tirunelveli to first speak on suture GAT.
Good morning, one and all. I would like to thank TNOA and my mentor, President Dr. RK sir, for giving me this opportunity and a wonderful platform. So today I'll be speaking on why GAT is my choice of minimally invasive glaucoma surgery. So minimally invasive glaucoma surgery, or MIGS, which was introduced in the field as a choice for mild to moderate glaucomas or as a bridging procedure, continues to evolve more than that. The impact worldwide seems to be growing day by day. These procedures are considered minimally traumatic with good safety profile, good IOP lowering efficacy. They target the natural outflow pathway, that is the conventional outflow pathway through the trabecular meshwork into the Schlemm's canal. Today, we'll be restricting our talk to the trabecular meshwork based procedures involving GAT, eye stent, and KDB. So let's do a deep dive into the literature and see why GAT will be my procedure of choice. So efficacy-wise, GAT has shown clear supremacy over eye stent or eye stent inject, considering the fact that GAT targets the entire 360 degree of the trabecular meshwork, while eye stent targets only a portion of a trabecular meshwork. The same holds true for the KDB as well. And even long-term outcomes are good for GAT, showing a 45% reduction in the intraocular pressure, as well as a good reduction in the number of medications. So let's weigh it against the alternatives. So this study, which compared GAT versus KDB, showed good reduction of IOP and medications in the GAT group. And the point to be noted here is that more IOP lowering medication procedures were required after KDB goniotomy. This study which compared GAT versus eye stent, you can clearly see that the intraocular pressure reduction achieved in phaco GAT was more than twice that was achieved with the eye stent group. And it also showed a good reduction in the anti-glaucoma medication use as well. So when it comes to eye stent, we don't know whether 2 eye stents are needed, 3 eye stents are needed. And literature shows that definitely more with each eye stent, there is a significantly greater reduction of IOP. But this comes at a greater cost. So from the economy standpoint of view, GAT is a clear winner when compared with eye stent and KDB, which comes with a heavy price tag. Not only economy, we should be looking at the economic efficiency as well. This is a recent article which was published in IJO by none other than my debate counterpart, Dr. Prasanna, who has clearly stated cost per 1 millimeter IOP reduction. This is double for eye stent when compared to GAT. So let's look at a case scenario. Here is a 60-year-old doctor who is a female doctor, and she was diagnosed with open angle glaucoma and on maximal medical therapy with an intraocular pressure of 21 in the right eye and 19 in the left eye, with cornea, thinned out cornea and advanced cupping. These were her visual fields, showing a macula split in the right eye and advanced field damage in the left eye as well. She did not want to undergo trabeculectomy considering the risk. So she opted for GAT with phaco. And these are the results. The IOP lowering in the right eye was very good, and she was very happy at the end of the procedure. And she opted to undergo GAT in the left eye as well. And you can clearly see good IOP lowering efficacy in the left eye as well. So the point here to be noted is GAT is not only efficacious in the mild, moderate group, but also it is being efficacious in the advanced group. So this is a paper which shows good success rate in the advanced group as well, and good IOP lowering of 40.1% in the advanced glaucoma as well. GAT is being explored not only in open angle glaucoma, but also in angle closure glaucoma with good results, and in pseudo exfoliative glaucoma as well. So let's look at another case scenario. Here is a 25-year-old female who was diagnosed as juvenile open angle glaucoma in both eye, again on maximal medical therapy with high IOP, thin CCT and advanced cupping. So this patient, we underwent trapless trap in the right eye. And the problem was the patient developed 2 months hypertonic maculopathy in the right eye with an IOP of 4 millimeter mercury. So she chose to underwent GAT in the left eye, and you can see a good efficacy in the left eye in terms of IOP reduction. So GAT is being applied to juvenile open angle glaucoma, also in other secondary glaucomas following vitreoretinal surgery. It is even being tried in uveitic glaucoma, neovascular glaucoma, and even in rare case scenarios of secondary glaucoma after bilateral acute iris transillumination. And even after failed procedures, after failed eye stent, failed incisional surgeries, even along with bleb excision procedures. This indicates the versatile nature of the procedure. This is a collage video from our institute showing GAT being done in various case scenarios in open angle glaucoma, in angle closure glaucoma, along with GSL, that patient of juvenile open angle glaucoma, etc. So again indicating the versatile nature of the procedure. This snapshot, which shows the proline suture coming out from the other end, is a real moment of hooray for any GAT neophyte surgeon. So from the surgeon's perspective, surgeon is happy with good outcomes. From patient's perspective, patient is happy because of early recovery and less follow-up needed. So like any procedure, GAT also has complications, with hyphema being the most common reported complication, and also IOP spikes. But these are usually infrequent and mostly transient complications for trap surgeons like us. So with eye stent, it has additional set of complications like device-related complications, obstruction, device malposition, device failure, and even rare cases of endophthalmitis has also been reported. The impact of GAT continues to grow worldwide, with mounting evidence and also more and more countries accepting GAT worldwide. So to summarize and conclude, GAT has shown good efficacy with a good safety profile. It is economically efficient, and also it is a versatile procedure. And that is why my choice in MIGS will be GAT. Thank you.
Thank you, Dr. Madhavi. I think your videos are very nice, and really enjoy seeing the elegant GAT procedures after the initial learning curve and so on. And we'll come to the discussion after Dr. Prasanna's talk. I think for those of you who don't know Prasanna, I think there are very few who don't know who Prasanna is. Prasanna is the rising star in glaucoma, and a youngster and active in many forums. And you can see the his qualifications and his he has, I think, published, to my knowledge, more than 100 peer-reviewed publications in the last 3 years. So, Dr. Prasanna, I think your reputation precedes you. I now invite you to speak on MIGS with regards to the expensive KDB and the eye stent.
Yes, sir. Thank you, sir. Am I audible, sir?
Yes, Prasanna.
Yes, sir. Thank you for the kind introduction and the opportunity, sir. So I'm ready for the battle with Dr. Madhavi for the next few minutes. I thank the judges, the TNOA, for the opportunity, my moderator Murli Ariga, sir, as well as the elite panel. I'll present 20 points today in a stepwise manner as to why the segmental, that is the KDB or the eye stent, is superior to the suture GAT. So let us go to the topic, minimally invasive glaucoma surgery, the KDB and the eye stent perspective. So my journey started in 2019 in the World Glaucoma Congress, and I'll just be sharing my own personal tips along with the literature, review of literature. So micro-invasive glaucoma surgery, point one, is it the suture GAT really a micro-invasive glaucoma surgery when 360-degree trabecular meshwork is destroyed, point one. Whereas with eye stents and KDB, it's more ab interno approach, minimal disruption of anatomy, it's an efficacious procedure and a highly safe procedure. So again, citing the same publication that my counterpart cited, all on a humorous note, madam. So I will stick only to the classification of the stenting devices and the incisional devices, that is eye stent inject, suture GAT, KDB, and bang also, which is cost effective. I'll add that also to my armamentarium for this discussion. Along with that, I also learned few techniques last week from Murli Ariga sir on gonio scrubber, TNOA and Espilat, which is not part of today's discussion, but I'll stick around this. We'll leave the suprachoroidal stents for later. So yeah, these are some of the videos that I wanted to start off with. So we have the direct gonio, which is the art of the procedure, be it the suture GAT or be it the MIGS. We all need to do the procedure with the direct gonio being the main skill that we want to. I'll stick on to the videos of TVG lens and the eye prism glaucoma lens that I am using for my cases. So the first generation eye stent or the G1 as commonly called. So I do agree with Dr. Madhavi that there is a slight learning curve, but the learning curve is not that difficult compared to the suture GAT. So it is relatively easier. Along with the direct gonioscopy, this procedure is relatively easier, is what I would argue against that. And the results, 68% of the patients who received eye stent along with the time of cataract surgery, it should be combined with the cataract surgery. The medication free at 12 months were very, very good. And the IOP was less than 21 millimeters. There is also the eye stent 2, the generation 2 eye stent, where you can see not one but 2 stents are being placed, which is also promising and very upcoming. You can see in this video there is only a minimal ifema. I would like to point out that point as well. The ifema that occurs with an eye stent or with segmental incisional trabecular meshwork surgery like a KDB or a bang, the ifema is micro ifema compared to the macro ifema that may occur. All the results you can see here also, 84% of the eyes, all are European literature. Indian literature are due to be published yet. My publications are also due. So 84% of the eyes with eye stent phaco were medication free at 23 months compared to 67% of the eyes which only got phaco. And I was talking about the cost economical counterpart that I have today for my defense. The KDB and the bang, a simple 26-gauge needle bent the other way around, that also can be used for an incisional trabecular meshwork surgery, where only a 100-degree or 90 to 100-degree trabecular meshwork is what is actually what is needed, and it costs nothing. Not even the 50 or 60 proline suture cost is what I believe in. And this is the beautiful cleft that you can see in the post-op, and even you can see the bleb here, the ostium here rather. So even post-trabeculectomy patients, incisional trabecular meshwork surgeries are holding good. And this is the beautiful cleft that you can see in one of my cases. And coming to the KDB, KDB blade here, 57.7% of the eyes experience reduction in intraocular pressure of up to 20% reduction of intraocular pressure. And there are so many different techniques with the latest KDB blade that you can see here in this video. Yeah, I'll just forward the video for want of time. You can see it's more controlled rather than the bang because this is much more elegantly 3D printed. There are 3 different techniques. The outside in, where first we can go from the outside from both sides and come the other way around clockwise and anti-clockwise. Then we have the inside out technique. So different surgeons will be comfortable with different techniques. The inside out technique here. And then we have the mark and meet technique where you mark a particular quadrant and then come in. So right, these are the points that Dr. Madhavi raised against even in my article, where I would like to counteract this. Eye stent, yes, they have less Indian data. The replicability is questionable. And in Indian scenario, we get advanced cases. That is a good learning, a difficult learning curve. And the approximate cost is very high. So yes, we're ready for the battle. These are my references. Point 1, trabecular meshwork has an important physiological function. It has a phagolytic action as well as a mechanical pump itself. So are we doing justice in destroying the trabecular meshwork is point 1 that I want to ask my counterpart. Whereas in eye stent, we just bypass, or in KDB, we just destroy only 90-degree, not the entire trabecular meshwork. Point 2, there are positives of eye stent, excellent safety profile, even for KDB. Tissue preservation is something that I want to highlight. And the stability of even eye stent and KDB is also, studies are coming up. There is a good disease stability over 5 years. Point 3 is it's truly micro-invasive, because is suture gap truly micro-invasive, whereas in eye stent, only 1% of the trabecular meshwork, whereas in KDB or in bang, only 30% of the trabecular meshwork is destroyed. Point 4, fate of the trabecular meshwork. No long-term studies to what happens to the trabecular meshwork after suture gap. Does it go for fibrosis? Will the anti-glaucoma medications work after the trabecular meshwork is destroyed? What will happen to the trabecular meshwork's role in reacting to the medications, especially the one that causes the pathway to the trabecular meshwork pathway medications I'm talking about. Point 5, the data pool. Global data, we have good data of 10 lakhs, which says that eye stents, KDB are good compared to suture gap. Compared to suture gap, most of the data from a single center or from a single surgeon, I feel there is slightly skewed in that particular point of view. And learning curve for manual surgery or the manual suture gap is slightly higher is what I feel according to my personal opinion. Sometimes the surgical time, personally for me, it has been more greater than a trabeculectomy. Point 7 is skill-based. In this particular patient, you can see identification of the Schlemm's canal, where I'm using the MVR blade to make sure I see the or unroof the Schlemm's canal. And this is one particular patient, suture gap patient of mine, where I tried to insert the 60 proline and it started kinking the other way around. It's not as easy as it sounds. Great surgeon's hands, maybe with a better learning curve, it may work well. But for neophyte surgeons or during my earlier cases, I've experienced this kinking that I just showed you in this video, where you can see that the blade just comes out. This is I just wanted to confirm whether I'm in the right plane. So I just did some visco and the cleft was beautifully seen. And then I had to end this case by doing a bang because I was not able to proceed with the gap. There was more cheese wiring And especially in the early stages of mine, I felt, does it really go 360 degree? It's very questionable. That's one point I just wanted to put off, at least for the early stages. And cheese wiring of the trabecular meshwork, not all trabecular meshworks, the suture can easily be passed to. Yes, we can argue that iStent may also have the same problems. When you try to place, the cheese wiring can happen and the iStent may not stay in place. I do agree. But the learning curve or the surgeon bouncing back from that phenomenon, this is one of my cases where it was still cheese wiring when I tried to place the iStent. But again, in the next scenario, you can see that I was able to assess the tissue's integrity and I was able to place the iStent in that particular patient. Point 9, suture related issues. When you try to pull the suture may break off when you try to pull it. It's not easy as it sounds. There may be false passages again that can happen. Bleeding from the lens canal. Intraoperative bleeding can cause difficulty in the vision. And
Problems can be, you can have bleeding from the Schlem's canal, you can have a non-advancing suture, you can have a false passage.
This is, I'm using Dr. Swati ma'am, one of the pioneers in suture gate, for my defense here. And yeah, we're not fighting, it's still going in a comical way. And few more points. High risk of macroemphysema compared to the microemphysema in the incisional surgeries. That is one point I want to point out.
But the patient will get definitely worried because vision will drop from 612 to hand movements or 1/60. So
can hear Swati ma'am telling the vision dropping from 612 to hand movements. So that is one thing. Even you can see the pictures here from post-op day 1 to post-op day 30 on the right hand side. It takes that much time to improve the visual acuity. That is one point I wanted to use in my favor. Again, this is one study what Dr. Madhavi pointed out. I've used the same study. Phaco GAT definitely has better IOP lowering, that is proved. But at the same time, safety profile, the bleeding, that is on the other way around. A monocular patient at the same time who has an high risk of bleeding, will we do a suture GAT with Phaco or will we do a Phaco with iStent? That is point 11 that I want to bring out. Again, in this paper, you can see the macroemphysema. It has a negative effect of post-operative macroemphysema. The results are good. The IOP reduction is good, but the stable boat theory where if the IOP is reducing, can we trade the hypotony, emphysema, and the decreased visual acuity from 612 to the hand movements that even Swati ma'am was telling? Can we really do that for this particular incident? That is where we also come up with a combined images proposal where you can see me placing an iStent as well as doing after 3 or 4 quadrant hours slightly away, you can see after the iStent bent angle needle, abentino needle goniectomy or KDB can also be performed where you can see a combined images which is due for publication in the next edition of IJO where I have presented on this. It is a point to ponder because the open system is created and it's not a closed system, but the results are very promising. Point 14, very basic. During the early stages, I was not able to create the mushroom that Madhavi ma'am pointed out where with the cautery, I used low temperature, but the mushroom shape was just not happening. It took some time to even learn that. Reproducibility, long-term follow-up, that is one thing that is questionable even in Indian eyes. And 16, the peripheral anterior synecdoche after blank cleft closure. Again, this is one of the presentations of Swati
you can see some blood reflex from the Schlem's canal or some blood clots when you press the gonio while doing post-operatively. You can see.
So peripheral anterior synecdoche is the point 16. Sometimes even a shallow AC or a malignant glaucoma.
But if we have a false passage and if you landed with a correlative detachment, then we have to manage it conservatively using system.
So that is something that I wanted to use for my defense. Point 18, even in post-trap failure patients, incisional trabeculectomy surgery and even iStent is well documented in literature. Premium practice, just a change in mindset. Premium IOLs and flax can be done with insurance. Can we move towards iStent also? Or even in trabecular meshwork, incisional surgeries like KDB. Point 20 is an accessory point where you can see that no financial disclosure, but in this video with the instruments given by Glaucos, even you don't need to hold it, and with that your both hands are free and you can do even in suture GAT or an iStent. So to summarize, I think images is there for the future as well as incisional trabeculectomy surgeries as well as the iStent that I was talking about, post-tab and tube, it is very useful. Incisional is very good. Implants, it's still questionable, time has to say. And long-term studies, there are good long-term Western studies, Indian studies are still due to be published. Good 20% IOP drop. Try to learn or focus on your direct gonioscopy, be it the incisional suture GAT or the KDB, where move the microscope towards you, keep the patient's head slightly up and make sure you practice on direct gonioscopy, direct gonioscopy, direct gonioscopy. So this is a bloodless surgery that we are pointing out. I once again thank the TNOA team for giving me this opportunity for presenting my 20 points against my counterpart. And this was a glaucoma activity that we undertook. And thank you once again, judges, moderator, and the elite panel for the opportunity.
Prasanna, I think 20 points for a topic like this. I think 20 points for. I think it's an amazing debate, and I think we're literally speechless, and we can't. I'm not able to say anything against you with the 20 points which you highlighted. I think
So
to moderate.
can I give a counter?
You don't
Before
have
going
any
to the
chance. You
moderation?
already had your chance, and he's got 20 points against you, and I think he has played your video as well, or your colleague from Arvind Pondicherry.
Yes, sir.
I think. Yeah,
Madam-
please comment. Yeah, a quick comment from you before I ask Dr. Venkatesh to say something.
Yes, Madhavi. Madhavi.
Yes, sir. So basically, in 20 points, there were a lot of overlapping points, I felt. Like point number
Yes, sir.
1, 2, 4, 7, everything was regarding trabecular meshwork.
Every third
He
point was
divided it
repeated.
into- Yes, every third point was repeated. So I can make it into 3 points. Maybe he was talking more about the trabecular meshwork and talking whether it's actually minimally invasive. And the second point was skill. Point number 6, 8, 15 was regarding skill, I felt. So skill, again, iStent also needs skill. And even GAT, I agree that there is a much more longer learning curve. But once you learn, that is not a big deal. Even when you are doing iStent, you can do GAT also. So the third point was regarding bleeding and peripheral anterior synec. Yes, I also showed in my slide, there are chances of high FEMA, but that is very minimal and literature was also supportive of that. Yes, we have some patients who go for high FEMA and vision, defective vision as well. So that is my counter in short.
Dr. Venkatesh needs no introduction, and I think he is a proponent of the suture GAT, and what does he have to say to Prasanna's counter of 20 points against the suture GAT?
Murli, it's very simple. I think there's no debate between GAT and iStent. Okay, and then we cannot debate between a minimally invasive glaucoma surgery and a GAT. I think GAT is beyond that. Now, that is what we understand from the talk which even Davinder Gray, who was the founder of GAT. And now we understand that you can't say that suture GAT is cost effective. He was repeatedly saying that suture GAT is the way to go. It's even better than doing a catheter. Ideally, it's a 5-Prolin Prasanna than 6-Prolin. Okay, that's an important point to keep in mind. And definitely, like any surgery, there is a learning curve. That is what Madhavi is repeatedly saying. And many of our surgeons we see here have picked up in a very short time. As like your trabeculectomy or your cataract surgery, I think there is a learning curve in identifying, doing a proper gonioscopy like you were highlighting. Now, all those positioning, everything is important. But at some point, we have to understand that most of the studies which you showed and Madhavi showed between KDB and GAT is the ideal comparison. No, whether you do 100 degrees or 360 degrees. But most of the studies are retrospective studies. They are not direct randomized prospective comparative studies. And in these retrospective studies, if you go into detail, they found that most of the studies GAT were done on failed cases, and even in cases where they were on multiple medications, where the failure rate for other procedures is very high when compared to KDB. KDB was done as primary procedure, or it was done in medication naive eyes. So these are all the differences which we also looked at in some of the evidences. So it's very clear that if you are dealing with moderate to severe glaucoma, a suture GAT would be an ideal option. If you're again dealing with mild to moderate glaucoma, you want to remove the medications, you want to get rid of ocular hypertensive from a medication, then maybe you can think of iStent or iStent inject and things like that. And now we all know that in US and in European world, this is for cataract surgeons. They are making it much more simpler. Hands-free gonio. They're making it simpler and simpler so that anybody can adapt. As glaucoma surgeons, I think we need to see and weigh the results and see the cost of it, and then see which would really benefit for a little longer time. Thank you, Murli.
Thank you, Dr. Venkatesh. Dr. Vijaya.
Very nice debate, both of you. Congratulations.
I think we can give them another half an hour to fight it out.
Yeah, I think with the time we will definitely know more, gather more evidence. But if I want to emphasize one point, I want to emphasize a point. There is something called floor effect that applies to any mixed surgeries also. What I mean to say is, for any mix to work, the trabecular meshwork should be functional at least partly. If the trabecular meshwork is diseased totally, and if it is not going to help, if any kind of mix then there is no point doing GAT or any other procedure. GAT may be working even in advanced. If I remember, I think she presented the success rate is around 47% even advanced glaucomas. The reason may be there it has reached the floor effect and the trabecular meshwork is totally diseased. There is no question of GAT helping them. So you have to keep that in mind. Don't go by blindly that these procedures will work for any form of glaucoma. You should have some amount of functional trabecular meshwork. That is my take-home message. And you can choose what you want depending upon your patient profile.
Thank you, ma'am. I think in the interest of time, I think we really have to move on. Otherwise, we really have lots to discuss with regards to the type of MIGS, the choice of patient for which procedure to do and so on. I think we have to move on to the next topic, which is for advanced glaucoma, refractory glaucoma, we used to have the cyclocryo. Then we had the diode laser. And now, of course, we also have the various glaucoma drainage devices. For somebody with refractory glaucoma, what would you choose first? Would you do a glaucoma drainage device, or do you go in for something like the newer generation micropulse diode laser and hope that that would lower the intraocular pressure? We have two eminent glaucoma specialists who are going to speak. I think both are from Arvind, Madurai. And I now request the speakers to start. I think first we would have a speaker speak about the glaucoma drainage devices.
Thank you, Murli, sir. Am I sharing the screen, sir?
Not yet.
Okay. Is it visible, sir?
Yeah, please go ahead. Yeah, start.
Yeah. Thank you, Murli, sir. Thank you, RK, sir. As glaucoma surgeons, maximal medical therapy inadequate, trabeculectomy fails or at the risk of failure, we know the solution, the glaucoma drainage devices. Or we also know the destruction, cyclodestructive procedures. Is it really? No, it's not me saying, but the word itself describes micropulse, slowly, gently, destroys the ciliary body. A very good afternoon, everybody. I'm Dr. Deepa Ishrik, talking on the topic refractory glaucoma in seeing eye. So let's not just beat around the bush. Let's hit the nail right at its head. Glaucoma drainage device. We have four major types. The first one, the non-valved implants, Molteno and Barwell. The valved implants, Krupin and Ahmed. So now we have our own Desi Jugaad as well, which is novel, low-cost implant, our Oralab drainage implant. Now we have studies from the data, which from the literature review have compared all the type of valved implants. Now the success rate of different valves are about approximately 70%, and the mean IOP lowering is at least 50% from the preoperative intraocular pressure. Now, when we speak about the refractive glaucomas, the first thing which comes to our mind is the neovascular glaucoma. Yes, the cumulative success of neovascular glaucomas is 57% according to the Steve Gary sir's paper. Now we have cumulative success of Ahmed and Barwell's even higher, almost about 65%. There is a mean follow-up of 58 months, and there are 13 different studies across the continents, and this is ample evidence enough. Next, we have uveitic glaucoma, and yes, with astounding outcomes. The cumulative success being 86.83%, and the rate of Ahmed and Barwell in the same range of 94.3%. We have a mean follow-up of 85 months here. The next in line is developmental aphakic and pseudophakic glaucomas. Here again, we have ample clinical evidence and time-tested evidence. Now, the undisputed king in pediatric glaucomas is the GDD. It's likely to remain the mainstay treatment. Watch before you speak, Sharmila ma'am, because the little eyes are still watching. Because I can say this with confidence, because pediatric refractory glaucomas, the micropulse is not for pediatric eyes. Though we have a paper which has compared pediatric refractory glaucomas. Here again, the success rate in adults was only 72.22% versus 22% in pediatric patients. So 7 out of 9 pediatric patients required reoperation only during 12 months of follow-up. I repeat, 7 of 9 pediatric patients required reoperation. So now here Sharmila madam must be thinking that they were not prepared for this theory, but reality check, ma'am, reality is different. Now coming to failed filters, again, yes, of course, the tubes help. The cumulative success is 69%, the mean follow-up being 12 to 37 months. The next we have in line is success of repeat tubes. Even if the tube fails, in the plan B, we still have tubes versus micropulse. The tubes work better according to the PTVT study. So not only revealing all the data or putting forth our evidences is enough. Strength is one when we say strong is the one who knows his challenges, his weakness, and tries to adapt. So adaptations to enhance the outcomes and safety. So we know AGV causes diplopia, which is common with barbell glaucoma implant, but design modifications have markedly reduced its incidence. There is also hypotony, but valved implants reduce the risk of post-op hypotony. There are ab internal stenting and ab external ligatures, which we can do in non-valved implants. We know leb encapsulation can occur, but frequently seen with AGV than other implants. But early aqueous suppressants do help. Equivocal beneficial role of antifibrotics also are there. Tube exposures can happen, but still we can modify them too. So according to coming to some other different studies now, we have the Cochrane study. The commonest adverse events across all the 5 studies is the Cochrane review of cyclophotocoagulation, the hypotony and the thysis bulbi. No significant difference in the incidence of these events with the type of surgery. Hence, the hypotony caused by micropulse is more dreadful in comparison to the hypotony. I'm not denying the fact that the GDD hypotony is not caused here, but there are ways to address hypotony. In fact, we have ab internal stenting, ab external ligation, device explantation or tube removal, exchanging for a smaller device, and truncating the lip end plate. Whereas micropulse CPC, even though it produces hypotony, but then there is irreversible hypotony which happens. Now, this has been reported that and there is no difference between the types of micropulse or the cyclophotocoagulations. Now, another study wherein a prospective comparative study between endoscopic cyclophotocoagulation and the Ahmed drainage implant in refractory glaucomas, it is quick to act when the need arises. There is prospective direct comparison of AGV versus cyclophotocoagulation. And this study suggests that there is early IOP reduction in AGV. In valved GDDs, it's faster than Usain Bolt. So rise to the occasion when it can, and let's not just fall status quo. Now coming to another study, wherein our own study of micropulse, where there is no long-term data, whereas the AGV long-term outcomes studied almost in 320 refractory glaucoma eyes, there is a 10-year data of 44%. Next, we have a study of micropulse, which is better than CPC. But still, if you carefully look at this study, it is limited evidence to support. It is only one prospective comparative trial. There are limited samples in each arm, if you see. And the comparison group is so dissimilar, with nearly 50% of primary glaucomas taken in the micropulse group and only 50% in the NVG group. Then still you say India won by 101 runs against Afghan, but still India West Pakistan is in no way comparable to defeating Afghan. Now coming to the climax of our story, our own paper, our own micropulse paper published by Sharmila madam. But let's see this paper in a different light. Let's read between the lines. So according to this paper, it's a retrospective study of 77 eyes. Okay, a majority of primary glaucomas were taken. If you note, hardly any NVG glaucomas were considered in the study. 14 out of 77 eyes required treatment or surgical intervention within 6 months. And almost no change in the number of meds from the baseline till 6 months. So now I can hear inner voice of Sharmila madam, I guess. If micropulse is not reducing IOP, then the solution is GDD. Now to finish, micropulse is an evolution of CPC. It continues to be inferior to this time-tested GDDs. It is just a short-lived temporizing measure. There is paucity of long-term outcomes and safety evidence. It is expensive. More retreatments, resurgeries in short term. Long-term and large-scale evidence across the continents and refractory glaucoma studies are needed before jumping to conclusions, and drug-free is a distant dream for micropulse. Hence, the undisputed champion is the glaucoma drainage device. But this reminds me also of an incident wherein a patient who was who was counseled for micropulse, came to my room to tell me that, madam, don't you think this micropulse or this laser is the rich man's laser? And that got me thinking, yes, micropulse, unlike endocytophotocoagulation, is a blind game, or you can call it the duck hunt with cuffs. See, we know that GDD requires skill. GDD is challenging, but still technical expertise is required because most vulnerable deserve the best. I would like to repeat that because the most vulnerable deserve the best. And here GDD comes to rescue in refractory glaucomas in seeing eyes. Thank you.
Dr. Deepa, are you still working at Arvind Madurai, or are you going to leave tomorrow? Dr. Sharmila happens to be your senior, and you're putting up pictures of her. You seem to be in an attacking mood that what she is doing and publishing is not correct.
No, sir, it was just because it was a debate with the proper disclaimer.
No, wonderful debate, and I think we should appreciate your guts.
Yeah,
your guts in going against a senior colleague and putting out her publications
so
and tearing it apart.
With folded hands, I give it over to
tomorrow.
Sharmila.
You have to work at Arvind Madurai. Yeah.
Already ஏதாவது plan இருக்கும் முரளி.
She probably, I think she probably has a bigger support, the HOD support for that is the reason. That is the reason.
No, ma'am, I can never dream of that. Then it was a debate, probably in good spirits.
Taken well.
Dr. Sharmila, what do you have to say?
Yeah, I am going to give it back to her. Deepa, can you stop sharing?
Yes, ma'am, right away.
Oh, Sharmila, இருக்கீங்களா?
இருக்கேன் சார். ஈஸியா விட முடியாது சார்.
Wonderful. Yes, you will. என்ன Sharmila என்ன பேசுறீங்க பாப்போம்.
1 minute, sir. I'm able to share it. Yeah. So, okay. Thank you, TNOA, for the opportunity, and especially Murli sir and RK sir. The last slide, what she told was, are we justified in putting our vulnerable patients to micropulse? So I would like to ask the same question to her. Are we really justified in putting our vulnerable patients who are highly refractory and who need an immediate intraocular pressure control? Are we justified in putting them to tubes where you have to wait for 6 weeks for the IOP to reduce? So are we still convinced that tubes are the ideal surgery in refractory glaucoma? Is it risk-free? Is it complication-free? Is it definitely giving a long-term intraocular pressure control? Is it free from resurgeries, revisions? Is it surgeon-friendly? Is it patient-friendly? Now look at the complications that Deepa has conveniently avoided, and she's not even touched upon it. Look at the rate of hypotony, shallow anterior chambers, loss of perception of vision, hypotonic maculopathy, diplopia, tube complications, endless tube complications, long tube, short tubes, tube retractions, tube kinking, tube movements, stenosis, plate exposures, endophthalmitis. I can just go on and on. And these are all the beautiful pictures of all the complications which were encountered. So look at the shallow AC, look at the hypotony which is seen, look at the choroidal detachments, look at the tube corneal touch, look at the corneal decompensation, tube blocks, etc., etc. I can just go on. Now see, the tube is just out of the eye. It is supposed to be inside the eye and serve the purpose. You see here, the tube is just outside the eye and how long it is there. And long tube, you can see endophthalmitis and whatnot. I can just go on. Now, look at the complications which has been reported from the landmark study, the major landmark study, the TVT study and the PTVT study. And across the various follow-up periods, see it's at 1 year, 3 year, 5 year, there is no change in the rate of choroidal effusion. There is no change in the rate of flat chambers which have been encountered, no change in hypotonic maculopathy. So you can see that how much of complications are being continuously present, irrespective of the follow-up period. And look at the amount of complications. It is more than 1/4 of patients undergoing tube surgeries. And look at the amount of resurgeries that we have done for them. It's just enormous. Can you think of putting another tube and again the cost involved with it and all the trauma the patient has to go through it? Just give it a thought.
And these are all the various studies which have quoted various reasons for treatment failure. Inadequate IOP reduction, which accounts for 50%. So the main objective is to reduce the intraocular pressure. You can see there's inadequate IOP control, reoperations for glaucoma, and then you have tube versus the tubes itself. There are different types of tubes, the valve tube as well as the non-valve tubes. Both are showing equal number of complications like shallow anterior chambers, choroidal effusions, tube complications, and the total rate of complication is also similar. Now look at the complications in the Indian scenario. Indian scenario, is it anything different from the Western population? No, not at all. The same rate of complications, whether it is immediate, intermediate, or the late complication. The total number of complications is around 30%. And look at the amount of choroidal detachments which are reported. It's really, really very high. And this is a major study which was published by Chandigarh group. And here they have compared both the valve as well as the non-valve device. Now you carefully look at this point. Dr. Deepa is telling that hypertony is not commonly seen with the valve devices. But see here, AGV is accounted for 38 hypertony and RD is also equally same 40. There's no difference, irrespective of whether you're using a valve device or non-valve device. So immediate hypertony, late hypertony, you still have hypertony, irrespective of whether you're using a valve device or the non-valve device. Now, I wanted to, just because there's no direct comparison between the two, I just picked up a few of the important complications seen with the tube and compared it with the micropulse. So look at the rate of shallow chambers and look at the rate of choroidal effusion or CD. You can see that 17% has been reported in the GDDs from various studies, and look at the micropulse, none. There is no shallow AC, no choroidal detachment seen. And look at the rate of loss of light perception. All patients in whatever reported in the studies are between 4 to 26% loss of light perception. Whereas in micropulse, it is only 2-line decrease in visual acuity. And also 50% of them regain within a few months or few weeks, they regain their vision. And look at the amount of IOP interventions for high IOP, 40% in the GDDs, whereas it's only 24% and also in the form of a repeat micropulse. Whereas here you have to go for a repeat tube. Imagine putting 1 tube, 2 tube, 3 tube. Just give it a thought. Now look at the comparison of the repeat treatments. These are all the major trials, the TVT, AVB, ABC, etc. And also the Indian studies. All of them have quoted close to 20% of resurgeries, retreatment, especially surgical treatment in patients who have undergone tubes. But compared to that, the micropulse, there is a chance for repeat interventions. Most of them responded well with a repeat laser or a diode, and a few required a repeat surgery, which can either be a trap or a tube, because we are not doing anything with the conjunctiva. It's conjunctival sparing. Now, most important of all, the mechanism of action. So we are subjecting patients with refractory glaucoma with very high intraocular pressure, where the optic nerve is totally compromised, and you want an immediate control of intraocular pressure. And my friend Deepa wants to put those patients or subject those patients to a tube surgery, wait for 6 weeks, and expose these eyes to a very high intraocular pressure and also lose the whatever remaining vision they have. So there is a delayed intraocular pressure, and we have something called as a hypertensive phase. They have to be on medications for a long time. And also the amount of intraocular pressure control is not very definite. It depends upon the size, the surface area of the implant, and also most importantly, the valve function. She said AGV, immediate intraocular pressure control. Last week, she was with me in the OT, and she knows very well an AGV patient which was not working because of the malfunction of the valve, because of the obstruction by the iris of the tube. So likewise, the micropulse, just go to the micropulse. There is an immediate instant intraocular pressure control. It has 3 routes by which it acts. It decreases the aqueous secretion, increases the UV scleral outflow, and it also has a pilocarpine-like effect. And my dear friend is quoting to all the studies which are related to continuous wave micropulse, where it is considered only for end-stage glaucoma. Today, we are talking about controlling intraocular pressure in eyes with good vision, where we are using a micropulse technology. Why micropulse? Because it gives energy for a shorter duration, and it relaxes for a few seconds. In that way, there is an on and off cycle which prevents collateral damage, and it also does not cause complications like hypertonia or phthisis, which was repeated earlier with the continuous wave laser. Now coming to the efficacy. Now these are all the various Western population which has quoted the efficacy rate, and all of them quoted between 60 to 80%. And look at the number of complications, it's very minimal. It is only uveitis, antechamber inflammation or CME, which responds with conservative management. But look at the efficacy of tubes over different studies. The qualified success itself is only 65% at the end of 5 years. So you can imagine what will be the rate of complete success. Now, are we justified in comparing tubes and cyclophotocoagulation? The continuous conventional cyclophotocoagulation was used only for end-stage glaucoma. Today, we are talking about comparing tubes with micropulse for eyes with good vision. So we are comparing earlier. So we are using whatever study she has quoted was comparing apples and oranges. So now we have been using it for eyes with good vision. Why? Because it's non-invasive. It produces little or less collateral damage. It temperatures the intraocular pressure. Very important, because it makes it come to a reduced level of IOP where it is safer to do an intraocular surgery. It gives an instant or an immediate intraocular pressure control, and also you can titrate the laser setting as per the patient needs. It can repeat it. Very importantly, you can repeat it. And the most important thing is the conjunctival sparing. You can always do a successful trabeculectomy later. It's a simple, easy technique. It works in anybody's hands. It's quick. There's no hospital day required. It requires lesser follow-up period, and it also gives a faster recovery. Now, this is our study, which has already made it easier for me. She has already reported about this. And here I want to say that because it is good, we have used this as a primary treatment. Why we have used it as a primary treatment? Because there are patients who come with 40 pressures and where every surgeon is scared to take those patients for surgery. In such patients, this is definitely a big relief because it helps us to temporize the intraocular pressure to an optimum level where you can take these patients safely for surgery. The surgeon is comfortable, patient is comfortable, outcome is good. But in our study, both the groups, whether you use it as a primary treatment or additional treatment, there is no difference and it gives equal efficacy. Now, this is a similar study which was reported by the Mayo group, and here also they have quoted that more than 85% of patients have intraocular pressure control of more than 20% from baseline. And you see here, very importantly, the complete success is 75% at 1 month, whereas in tubes, the qualified success itself is only 65%. And see the qualified success here, it is 93%. Now, because we used this as a primary therapy, I also looked at the PTVT results just to see how the difference is. The intraocular pressure reduction is similar, whether you use a tube as a primary procedure or micropulse as a primary procedure. But what is more interesting was the persistent presence of high intraocular pressure was seen in 60%, close to 60% of patients when you use tube as a primary treatment. And in ours, it was only 30%. Likewise, additional intervention, that is 60% of them require an additional intervention in the primary tube group, as opposed to only 24% in patients who underwent primary micropulse. So look at the cost effectiveness. She's saying it is very expensive. Has she ever calculated the cost of the AGV, the amount of medications that we have to use, the follow-up visit which is required, patients who come from very far, a patient has to lose his job for waiting for so long, accompanying person, the travel costs, cost of resurgeries, etc., etc. It is definitely a huge number. Whereas micropulse, you use a single probe, you schedule the patients on a same day, as the cost of the probe is distributed between patients, lesser postoperative visits and other associated costs. Now, surgeon and patient factors. It's very, very difficult to train doctors or patient going through or a surgeon who's going to learn these procedures, because there are very few institutes with trained for tubes, and also for surgeons to perform these tube surgery. It's very difficult because it involves muscle dissection, technically difficult, and it's definitely very, very time consuming. And imagine the patients. For older patients, very, very old patients, high-risk patients who have to keep coming every 2 weeks to the hospital. Just think about that. Now, so we are all living in an era where there is always some development happening. So we have all long back, we have moved out from test cricket, waiting for 5 days to see what is the result of the India-Pakistan match, whatever she's saying. And then we moved on to one-day international with 50, and now we are into IPL, and we are even thinking of making it only 10 overs, and we want something very fast. Like we can't even wait for 2 minutes to have the Maggi noodles. So that is the situation here. Are we justified in subjecting our patients with refractory glaucoma with such high intraocular pressure to wait for 6 weeks to allow the intraocular pressure to come, to wait for the suture to lyse out or to remove the supramid suture? Are we justified? In this time period, are we not subjecting our patients to a very high intraocular pressure and loss of central vision? And what about efficacy? Even after doing a tube surgery, you wait for 2 weeks, 4 weeks, 6 weeks, and finally, you just think that pressure is going to come down? Nothing. Still, the pressure is the same. So, what about the safety? The safety-wise, you see, performing a tube surgery is like directing a movie with Vijay Sethupathi. So, anybody who does it, anybody who takes it, it's always a definite result. But unlike that, if you perform a tube surgery, it's like directing a movie with Rajinikanth, where you require a long expertise, high cost involved, and finally, it will either be a hit or a miss. So you know what it is. I don't have to say about it. And cost effectiveness. My dear friend Deepa is talking about cost effectiveness. I keep seeing the way she's ordering things online. Every day, Myntra, Flipkart, whatnot. Every day there's a parcel. Only people who do surgeries charge so much for the patients can afford to do this. So my dear friends, please give it a thought. For immediate intraocular pressure control, for a safer option, for a better bet, you can always think about micropulse. Thank you so much for patient hearing. And I would like to thank my fellow Maitri for helping me in this presentation. Thank you so much.
Ronnie, Dr. Ronnie George is here.
Ronnie.
Hi, Ronnie.
Yeah, so
Ronnie, I think we are having a very combative session with two women from the same hospital who actually see the same kind of patients, slugging it out and saying that one is better than the other. And it so happens that the glaucoma drainage device, the RD, actually came from them. So what do you have to say on this?
Yeah, a very combative debate and very entertaining. But because both the ladies wanted to prove their point, they cherry-picked data to support them. So the point is that this was refractory glaucoma in patients with good vision. So at this point, the challenge is that you don't want the vision to drop, and at the same time, you want to get the pressures under control. So you have to have a slightly nuanced approach, because one of the things that we did a meta-analysis of all the micropulse studies and about 750 eyes. And what was almost uniformly seen was almost all studies reported a couple of lines drop in vision, which was as high as even 40% in some studies. In the study that Dr. Sharmila quoted from Cyril Doreraj, it was actually about 20% at 1 year, and that was one of the few prospective studies done with the micropulse. So that's something which is a little challenging. You do get loss of vision with the valves also, but that is typically longer term and not the shorter term results which have been seen with both the, almost all micropulse studies are maximum of 18 months. There's nothing which goes out to 4 to 5 years in terms of success. Having said that, if you have an eye which has already had multiple surgeries with very bad conjunctiva where putting in a valve also is going to be challenging, a micropulse is a reasonable option. But if the conjunctiva is fairly mobile and you can put in a valve without too many issues, the long-term success rate of a valve is much better known. The long-term complication profile of a valve is much better known. And in these eyes with refractory glaucoma and preserved vision, that may be the safer option to go. As we get more experience with the micropulse going forward with longer-term studies coming out, we may become a little bit more confident about doing them in even these eyes. I think that's what I would think.
One quick comment from Dr. Vijaya, and then, of course, Dr. RK would wind up the session. I think we're almost beyond the time. Thanks a lot, Dr. Rani.
Thank you. I think a very, very powerful presentation from two women. I think Diba is really gutsy to stand up to Sharmila. So good. Anyway, I think Ronnie has beautifully summed it up, and Sharmila has shown you're trying to compare oranges with apples. I think there is no way we can compare the two procedures. They both have a role to play in our armamentarium to take care of our patients.
Good.
Thank you, sir. You can your comments and conclusions, sir.
Yeah. My comments are really, it's a wonderful session. I have to thank Murali for coordinating this wonderful talks. The topics are wonderful, selected, nicely selected, and speakers definitely they've done their job beautifully. All of them. I'm really appreciate all the speakers. It's a wonderful reference and quote to support their topic. It's really and wonderful, lot of learning also, in this debates. Really, I'm very happy. Also, I have to thank Vijaya for patiently being with us for more than 2.5 hours and sharing her knowledge with us. And also, I have to thank Rani, Venkatesh, Mudin, and of course, all the speakers and others, Dr. Subhashini, for wonderful conversation. Now, as a formal
the TNOA office, Ranita has been outstanding in putting this together. I think she's been coordinating and communicating.
I have to thank her. Yes, Ranita is nice to do all the thing for me. Yeah, it's wonderful.
And Numerotech also, Sai and
Numerotech. Yes, Dr. Sriram Gopal is going to give a vote of thanks.
Yes,
our secretary.
Formal vote of thanks.
TNOA
Formal vote of thanks.
Yeah,
thank you, sir.
Yes,
thank
yes.
you.
My first thanks to Dr. Ramakrishnan, our beloved president, for putting this wonderful debate together. And I really appreciate him for putting this in a form of a debate rather than a didactic lecture, because this really brought out all the finer points, and it was really an entertaining session rather than listening to somebody just talk on a monologue. Thank you very much, sir. Thank you for all this. My second thanks to the judges, Dr. L. Vijay and Dr. Krishnadas, sir. To all the panelists who are present today, including Dr. Sujata Mohan, Dr. Satyen, Dr. Moideen, Dr. Venkatesh, Dr. Nagalakshmi, Dr. Subhashini, and Dr. Rani, and Dr. Chitra. And to all the people who took part in the debate, Dr. Premnath, Dr. Narayanan, Dr. N. Satyen, Dr. Kavita, Priyavardhini, Premanand, Dr. Preeti, Dr. Archana, Dr. Madhavi, Dr. Prasanna Venkatesh, Dr. Deepa, and Dr. Shamila. And last and final thanks to our wonderful moderator who really coordinated the session and made it very interesting and took the session forward, Dr. Murali Ariga. And a special thanks to our sponsors, Elegant, and a big thanks to all our people who logged in on a Sunday morning and enriched their memories and enriched their knowledge. And thank you, everybody. Thank you, sir.
கோபால், நீ 1 o'clock ஜாயின் பண்ணங்கிறது நல்லா தெரியுது. நீ கிருஷ்ணதாஸ்
குட் மார்னிங் எவ்ரிபடி எத்தனை மணிக்கு போட்டேன்னு பாருங்க. கொஞ்சம் 10 நிமிஷம் லேட். 11:10க்குள்ள வந்துட்டேன்.
அப்புறம் எது கிருஷ்ணதாஸ்
பத்தி கேள்வி கேளுங்க, நான் பதில் சொல்லுவேன்.
Thank you. Thank you all.
Thank you, Arthur. Thank you, sir.
Wonderful session.
Thank you so much.
Thank you, everyone. Thank you. Thank you all.
Thank you, Manjula.
Thank you, sir.
Thank you, ma'am.
Thank you, sir.
RK sir, thank you, sir.
Thank you, Prasanna. நல்லா இருக்கப்பா, ஹேண்ட்ஸமா இருக்க. நல்லா இருக்க.
Thank you, sir. இது பண்ணிட்டேன் சார் சைடுல. Thank you, sir.